কি তোমাদের নিজস্ব 5G দিয়ে বললে হবে না, মোবাইল দিয়ে? তাতেও তো আসছে না ভালো নাকি? ওরকম করলে হবে? এটা কাঁচ খুলে দাও নাকি, সামান্য একটু খুলে দাও তো। এসছে?
Yes.
পেছন থেকে না, পেছন থেকে না। Daniele, on
Check
details
this. Test.
কোনো
Hello.
problem?
Check.
নাও দিস ভিডিও, এই ভিডিওটা এবার দেখা যাচ্ছে, ক্যামেরায় অনলাইন দিয়ে দিয়েছে এটা। ভিডিও দেখা যাচ্ছে, ভিডিও অনলাইন দিয়ে দিয়েছে। এটা এটা স্মুথ লাগছে দেখছি। ঠিক আছে, এবার কেবলটা তুমি দেখে নাও। আর কেবলটা কানেক্ট হোক তবে তো এটা করবে। হুম, হুম, একদম একদম। লাইন দিয়ে তেমন কানেকশনই নেই নাকি, কিন্তু হয়তো লাইনে হয়তো আমার চেম্বারে তো হুল করে না। এইটা দিয়ে মোটামুটি চলবে তাই তো? লাইনটা হলে ভালো হবে। হুম? নিচ্ছে না না? ছবি আছে তো? ছবি আছে তো? ভালোই, মোটামুটি স্মুথ। হ্যাঁ। আমার তো অলরেডি সেট আপ তো সব আছে। তো আপনারা মাথা না লাগালে সকালবেলা এসে ইয়ে করবে। এই ইন্টারনেট নিয়েছে। আরে এটা ডাইরেক্ট वहाँ पिक्चर पूरा पिक्चर पिक्सल हो रहा है। প্রচুর স্লো। अभी ठीक आ रहा है। अभी तो लेंस करेक्ट हो गया। स्मूथ আছে না? फिर मैं एक बार डिस्कनेक्ट करके कनेक्ट हो रहा हूँ, ठीक है? डिप कर लो। ऐसे कैसे है तो? হ্যালো, না পিকচার বেটার। আপনি কথা বলুন তো।
Much better.
মাচ বেটার নো? আই থিঙ্ক ইট উইল বি গুড।
Okay. We are all eagerly waiting for your demonstration, sir.
Oh, thank you, sir. Thank you.
We have heard so much from everybody, so we said we must have everybody see the surgery. Yes.
হাত ধুচ্ছে। দেখে তো এসো না এখন। এখন ঠিক আছে? হ্যাঁ, বলে দাও তো। বলো, কেসটা সুন্দর বলো ফাইলটা নিয়ে।
Hello. Hello. Check.
Yes.
We can hear you.
Okay. Uh, Good morning to all. It's just I will before we start, I welcome you all to the Ghosh ENT Foundation. It's honor to you have all here virtually here. So today the first case which we are going to demonstrate is a 5-year-old child. The patient presented with the recurrent cold cough. The informant was the parent. The patient has a history of recurrent sore throat, mouth breathing, and on just clinically examined, we found the patient has a very enlarged adenoid. The patient has a grade 4 tonsil. I will just show the endoscopic picture. You can appreciate these are the endoscopic photographs. The patient has almost 90% blockage of the nasopharyngeal airway and a grade 4 tonsil, bilaterally enlarged. The patient will undergo the coblation assisted endoscopic adenotomy and microscopic coblation tonsillectomy. So just I will focus on these our OT setup. You can see the patient is already under anesthesia, draping done. Sir is now just introducing the mouth gag.
Hello.
Yes, we can hear you.
Hello. Today, I feel very lucky, basically, and I'm very honored. Feel honored because the few months ago, when Professor Kitana sir contacted me about the demonstration, and at that day, I was very happy and elated, basically, and sir told. It will be a you would be demonstrate and it will be telecasted all over India. Then this is the day. Thanks again, sir, for giving me this opportunity. I
You're
think
being
with your,
transmitted to 30 medical colleges
oh yeah, thank
all
you.
over India. And
Yes,
of
yes,
course in the auditorium.
yeah. Thank you so much. And from basic, because the lots of junior available to see this coblation tonsillectomy, first of all, a microscope required. So microscope, I prefer now the 6 magnification. But if initially any junior doctor may start with the 4 magnification. I use the now varioscope, but 200 to 250 lens is the I think sufficient. I now this way, and also before starting, see the tonsillar position. If external camera showing the this is the position, and you see this is the one oropharyngeal small suction tube. একটা perception দেখাই. Look here. This is the tube. I passes through the nasal cavity and it fits the oropharynx. Okay. And when coblation water will accommodate the oropharynx, it will be sucked automatically. So no disturbance of the area. Now the magnification will be 6 magnification. So better picture. And for demonstration, it will be very good.
Dr. Ghosh, we don't have your picture. Dr. Ghosh, can you hear me? Yeah, for the people in the auditorium, there is a little problem with his internet connection. He's just getting reconnected, so be patient. Dr. Rai, where with you? Wait a second. Here goes. Dr. Ghosh, where with you?
Hello. Good morning. We are connected with you now.
I'm not able to hear you. Dr. Ghosh, your audio is okay? Hello? Dr. Ghosh?
OT Kolkata, can you hear me? Just unmute and talk, sir. You are on mute. Technical person, I can see you are on a mute. Just unmute yourself, then a voice will come. Yeah, speak.
Yes, sir.
No, not coming. क्या हो गया दादा? Got disconnected. Hello. Got disconnected.
Hello. Hello.
Hello.
Hello?
Morning,
Yeah.
sir. Hello.
Yes. Can you hear me?
Can you hear me, sir?
Yes, I can hear you, but it's coming completely yellow. Can you on your camera, sir?
কেটে দিলে কেন এটা? অডিও ঢুকছে এখানে তো টিভিতে অডিও ঢুকছে অডিও ঢুকছে এটা কিসে দাঁড়া একটু দাঁড়া। হুম, নে।
Yeah. Hi, AV team. Can you hear us? Kolkata.
হুম, নে। এবার নে।
Echoes. এ কি প্রবলেম হচ্ছে? ইকো হচ্ছে পুরো। সেটা তো ওরা তো ইজি করে দেবে।
টাকাটা লাগিয়েছো? হ্যাঁ কোনটা লাগিয়েছো? হ্যাঁ লাগিয়েছি এবার দিয়ে দেখি।
Yes, sir. Now we can see you. Can you hear me?
Yes, we
Kolkata.
can hear you.
Yeah. No. Kolkata, can you hear us?
Dr. Ghosh, if can you hear us? Because if you can hear us and we can't hear you, it doesn't matter. You can still go ahead with the surgery. We can watch the surgery as you go along, but
Hello, can you hear me, sir?
yes, clearly.
Yes. Done.
Please go
Thank you,
ahead.
sir.
Thank you.
Continue.
Please go ahead.
এখানে কোনো কানেকশন নেই,
Sir,
হ্যাঁ?
can you hear me, please?
We can hear you very clearly and we can
Uday
see the
Rasta
picture as well. So you can just start now. Go ahead.
পাচ্ছি না। টু ওয়ে কানেকশন যে কোনো ভাবে নিতে পারছে না। আর টিভিটা আসুক এবার। একটা বেশি দেখানো যাবে না, একটাই দেখাবো কি করে সেটা ভাবছি। এই তো এবার মনে হচ্ছে এসছে।
Sir, can you hear me, sir?
We can hear you very clearly and we can see the picture
কথা বলছি শুনতে
also
পাচ্ছি।
very clearly. So please go ahead.
We can't hear.
You
Yes,
cannot
sir.
hear us?
Can you hear us, sir?
We can hear
Yes,
you.
yes.
Can you hear me?
Sir, we can hear you. Yes, sir, sir.
Okay, so please go ahead. We are starting.
Oh,
Thank
sorry,
you, sir.
sorry for the interruption.
Extremely sorry, sir.
No problem. Please go
Because
ahead.
of the sudden monsoon, sir, we are all getting falling apart, sir.
I know, beyond our control, not to worry, yeah? Okay.
Just we're about to start. How for junior, I just mentioning some point. How to prevent the bleeding, how to prevent suction ready nahi hai? So how to prevent bleeding, how to prevent the less pain. Suction ready nahi? So now I always prefer from upper pole, okay? Just pull. You should pull and look here how and maintain the pillar. So if you injure the pillar, then chance of pain is much more. Okay, now this way, just my setting is the 9.5 and I prefer the water pressure all time. Okay, now here my target to get the plane first. Look here the blue line. Okay, that is the peritonsillar fiber. Look here the peritonsillar fiber. Definitely you will appreciate the peritonsillar fiber.
Yeah.
Yeah, that peritonsillar fiber, I tell that there is the two attachments, the medial and lateral attachment. My target to the medial attachment, okay? So pain will be very less and no bleeding will be there.
This is the
Okay.
fiber of palatoglossus, right?
Look here. Now
You identify
the,
the capsule, Dr. Ghosh?
yes,
Just
basically
tell us
ECT,
the
this is
trick
the
how to
extracapsular.
identify the capsule during coagulation.
Hello?
Yeah,
Yes, sir?
how to identify the capsule from the upper pole?
Now basically this is the extracapsular. If we do the intracapsular, then sometimes capsule will be seen. Here, main target is the no injury to the muscle. The peritonsillar fiber. This look here, the peritonsillar fiber. This peritonsillar fiber is two attachment: medial tonsil or lymphoid tissue, lateral muscle. My plane is the towards the lymphoid tissue. Okay. And so if anytime secondary hemorrhage will be there, there is a very minimal because the main vessels all are not will be visible here. Look here. And slowly, if you see the plane, center,
Sir, which coagulation one are you using?
evac
Okay,
blade.
EVAC 70.
evac 70 and Smith and Nephew coagulated
Okay.
2.
What are the settings on your coagulation?
9.5 settings.
Okay.
9.5. I always prefer the 9.5 setting for adenoid and for tonsil also, both.
Sir, what about 7.3? Is it like a bit less? You use 9.5 setting?
I always use the 9.5 setting. Oh yeah, you see, this is the posterior pillar, okay? There's a main importance, look here, I'm not dissecting the posterior pillar. Automatically, you just see the lymphoid tissue and posterior pillar automatically will reach the posterior pillar. Look here, the posterior pillar. And don't hurry. Slowly, just in lower pole, slowly, if you
Focus the
pull, there is a chance of bleeding. Okay. Just slowly, you just, no traction here, just done the tonsillectomy. Look here, the plain, smooth, plain, one drops of blood.
Please show us the lower pole, it's not clearly visible.
Yes, sir. Look here, the lower pole. Okay.
Not focused.
Okay. Well, just 1 minute. This is the lower pole, okay?
Yeah.
Yeah. Look here, and just after completion, just check again, check and touch. Sometimes rub. If any RBC is there or not. If you see, then just coagulate. Look here, the beautiful plane. Now, the left side, I will try with the left hand, okay?
So can you do this intracapsular dissection in the left side for
Left.
patient?
Okay, next case, I will show the intracapsular, okay?
Okay.
Sir, you use operating microscope for doing coblation adenotonsillectomy for all your cases?
All cases with microscopic tonsillectomy and adenoid for adenoid endoscope.
Okay, sir.
Basically, if exophytic tonsil, then it will be easy for extracapsular. Okay. In endophytic, should be done because the here, look here. If you pull and start here, no. So pain will be very less. Plane will be clearly seen. This is the plane, okay?
Yes, sir.
This is a peritonsillar fiber. Look here.
Yeah.
Now operation will be very simple. Now just grip change. I'll show the grip change for junior. Look here. This is my left hand. Now I'm taking the wand with the left hand. Okay. Now slight bit hazy. So slight bit of focusing required. Now this is the now left-sided tonsil. Now this is the pillar, okay? Posterior
Yes,
pillar.
yes.
Just lymphoid tissues. Just see the lymphoid tissue. And sometimes grip change required. Now pull. Now if you pull,
Hello.
this is lymphoid tissue. So I'm removing the, look here. If you think sometimes in this coblation, if you know the technique, the primary hemorrhage and reaction hemorrhage, I've not seen. But sometimes secondary hemorrhage will be there. But I tell this is a spotting. Okay. How will I avoid this way? So just rub it, scratch. If any bleeding point will be there or any venous oozing point will be there, just coagulate it. So if you do this way, so pain will be less because, yeah, this is the, look here, posterior pillar, clear posterior pillar. So no voice change, pain will is very, very less because this is the muscle, parallel muscle, no injury, okay? And if you are clear, okay, definitely you will be happy. Now, sir, I think is the you are happy, sir?
Yes, excellent.
Excellent demonstration. Thank you so much. We're waiting for the adenoid.
Yes. Now the adenoid. Okay. Now you see how this way I just take the oropharyngeal suction tube, just palate retraction. Okay. Just I am going right side of the patient.
Sir, just one question I want to ask you, sir.
Yes, sir. Yes, madam.
Sir, for a junior doctor, do you think a junior doctor should start with full dissection method first before doing coblation tonsil, before doing tonsillectomy by coblation method?
Uh,
Because to get the
Uh,
plane,
I don't believe so. And my lots of junior works with me, so I don't say because the you should now you should think. Otherwise, you ask the junior they do without microscope mastoid surgery or tymplanoplasty surgery,
yes, sir.
tymplanoplasty. So why unnecessary? You should do the dissection method. No, because we are not doing any way without coblation any type. But you, if you know the proper coblation tonsillectomy, you know also the dissection method. No,
Yes, sir.
so basically the
So
plane
one
you
has
should
to know
know
the
plane
proper plane.
properly.
Uh,
Yeah, proper plane. Yes.
Ma'am, myself, Dr. Arvind Gupta, ma'am, I will just elaborate this answer, ma'am. I am
Yes.
working with the sir for the last 2 years. So initially during my PG days, we have learned that classical cold steel dissection method. And after I came to this center, sir just saw and make me learn this technique. So as I experience my experience as a junior, I will
Yes.
just tell no need to go for to learn the different techniques. No need to go from primitive to advanced. Means just learn one thing and the best thing. Means if we have the opportunity to learn the coblation, go for it. If no opportunity, then it's okay to learn to streamline or to have a surgical skill, go for cold dissection and then coblation adenotonsillectomy.
Okay, the only thing is the cost factor.
Yes,
The
ma'am.
cost factor. Not all people can afford coblation
Now,
tonsillectomy.
if doctors afford and patients afford, then only we do you do no. Basically,
Okay.
I have now 3 coblation machine in 4OT, 3 coblation machine. Because if patient ask me do without coblation, I never do free also with coblation also.
Okay, sir.
Because why unnecessary I will take any headache. Nowadays I am not interested to
luxury
take a
to you.
headache basically.
This is luxury to surgeon also.
Sir, are you reusing your blades or you are using every patient a new blade?
No, basically, we convince the only coblation method
No, sir, want reuse করি কিনা আমরা বলছি।
for reuse. Uh, Basically, this is the disposable. But honestly, sometimes it's possible. Possible if you do proper surgery, it is possible to surgery with a good wind. Okay. So now you see the adenoid. Okay. How
Endo picture not visible.
adenoid surgery will be
Endo
done.
picture you are not getting.
We need the endoscopy picture, please. We have the
Endoscopic picture shift
endoscopic
করতে
picture.
বলো।
Sir, I think you have bended the coblation one, no?
Yes,
Yes, ma'am.
This is the obtuse angle. External camera, please.
At
This is
what
the
angle you-
obtuse angle. Yes.
60-40 আমরা bend করে দিই।
40, 60, 40, the obtuse angle
You bend
here.
manually or some
Manually. One instrument is available with me, it's a nephew. 25,000 cost, but I have not purchased this instrument. The bend is the good option. In Gumpadi, so now,
so we are dissecting the adenoid from lower pole
yeah,
to upper
adenoid
pole,
same
or-
setting. Hey,
Yeah.
Devan,
Gotcha.
Gumpadi, not a problem.
So there is
So we
one
start the
question.
adenoid from the upper pole only.
Always I start the adenoid from upper pole. Okay.
Okay.
So there
This
is
way.
one question
Yeah, upper
from
pole.
the audience from Dr. Vikul Deshwal from
This way.
Faridabad. Can you please tell whether patient is in local or sedated in this tonsillectomy patient?
ওটার জন্য বলছো না? Oh, hello, sir. Please repeat the question.
So this is a question from Dr. Vikul Deshwal. Can you please tell whether patient is in local or sedated in this tonsillectomy which we have done?
No, general anesthesia. You always do under general anesthesia. This is the adenoid. Look here, how I do the adenoid from upper pole. Okay, look the movement of my wand. Look, and speed also. I don't prefer any block or clog of the wand. Is the 9 years or 11 years? It is 9 years. No, 9 years. It is 9 years. So adenoid slight bit of fibrosed. But look here how I am doing the adenoid surgery. And water speed, all time water speed. Look here, my stroke. Now debulking. First debulking.
Supposing, sir, if the one gets blocked, you will take it out and you will.
To prevent the block, I am two way. You should maintain the water speed, good suction, and also speed of your hand. If you do slow surgery, then there is a chance of block, and water speed is less, then there is a chance of block. I never use the brass or something to clear because I am not habituated to block basically. Look here, and slowly I am going the lower pole. I will complete the full boundary of adenoid. Okay. This is the upper pole from basis sphenoid to passavant ridge. I'll show how I'll complete the adenoid full boundary. Now,
So how to identify the periosteum in the upper pole? When
yes,
is the
sir.
upper limit?
I'll show, sir. So for that reason, I always use the upper pole first, and I will show every basis sphenoid periosteal area. I'll show periosteum also. Just give me 1 minute.
And how to identify the passavant ridge?
This is the passavant ridge. Okay. From upper pole I've started. Now I complete my surgery and also complete from fossa Rosenmuller. See where I remove the from fossa Rosenmuller. I'll show.
That's the passavant ridge.
Look here the student tube, okay? And this is the thorax tuberous. So if you remove slight bit, then
Medial part, if you'll take out, so won't much problem.
Yeah.
This thorax tuber is medial part, if you'll divide.
Definitely. Should not injure the tube. Look here, how I'll remove the fossa Rosenmuller. Press it, press and move, press and move, press and move. Don't go this way. So if there is a chance of bleeding, the hidden area, sometimes bleeding will be there. So problem. So for juniors, do press and move, press and move. Otherwise, another technique, the angle endoscope. Should use the angle endoscope. Other way, you remove some part, then you will see the fossa Rosenmuller adenoid. Okay.
So Dr.
Now,
Ghosh, do you scare of the carotid pulsation sometimes coming from the passavant ridge area?
carotid pulsation or subclavian artery, there is a lots of distance, a few miles away. But carotid pulsation, sometimes I have seen the during tonsillectomy, but under magnification, there is no risk, no chance of any problem. Now you see the buccopharyngeal fossa, the posterior limit. Now you see the beautiful buccopharyngeal fossa.
Yeah.
Yeah. So this is the muscle area. And now if you go, this is the perimyxal or buccopharyngeal fossa. If you go upper pole, then you will see the periosteal, okay, basis sphenoid. So everything from upper pole to lower pole, everything is clear. So you should assure the patients, I'll do the such way, there is no chance of recurrence. No chance, not just 2%, 3% chance. No chance of recurrence because it is a benign tissue. If you do proper surgery, then why the recurrence chance?
What is the
So,
post-operative management?
post-operative managements are only good antibiotics 7 days to 10 days, nasal spray, nasal wash with normal saline, good nasal saline, nasal drop 7 to 10 days. And for tonsillectomy, adenoid less pain, but tonsillectomy sometimes pain. So painkiller, ibuprofen with paracetamol for 7 to 10 days.
Hi, sir. This is Dr. Rajat Bhatia from.
And good gargling to prevent the pain in the throat. Good gargling.
Sir,
And-
this is a beautiful dissection you're doing. Just had one question. Do you routinely bend your wand to reach the choanal top end, or you prefer to use it as it is?
কোশ্চেনটা শোনো তো আমি শুনতে পাইনি
So do you bend the wand to reach the choanal superior
Oh,
most?
sometimes according to condition of the adenoid. Sometimes in adult, sometimes bending more required. Look here,
Yes, sir.
bending
So
not
we
so
not-
much. I'm reaching the upper pole, no? That is
Yeah,
sufficient. So this is sufficient. Sometimes in case of adult, sometimes difficulty. So bending required more. Look here, I'm now nearly
The upper part of
completion
the
of the
choana.
adenoid.
Is it the upper part of the choana you are taking out?
This is the opposite side. I'm doing the opposite side now.
Sir, regarding that post-operative advice you told just now, if a child with adenoid hypertrophy has history of allergy, do you prescribe some antihistaminics and nasal steroid sprays in the
Intranasal corticosteroid for 2 months, our hospital protocol, and anti-allergic definitely for 1 month. Because sometimes some patients have an allergic problem also. And sometimes it's very difficult to understand with allergy problem is there. So we should give, we give intranasal corticosteroid for 2 months because if we do endoscopy after 2 months, then 100% epithelialization complete. So if you give the intranasal corticosteroid for 2 months, then I think a better result. Otherwise, sometimes some slab, sometimes some secretion will be there in the nasopharynx.
So you give, sir, which spray, mometasone nasal spray or?
In case of children, mometasone spray, or in case of adult, young adult, more than 12 years, intranasal corticosteroid, fludrocortisone propionate.
Sir, what are some of your very absolute indications for doing adenoidectomy, sir? Some very
Absolute indication in case of tonsil adenoid is the OSA, obstructive sleep apnea.
Yes, sir.
Obstructive sleep apnea, absolute indication. I don't prefer too much tonsillectomy, but adenoid I prefer. If nasal block, in our center, routinely we do the nasal endoscopy. If patient complain nasal obstruction and also some mouth breathing and repeated nasal secretion, and we see the nasal block with endoscopic findings, then we offer the endoscopic adenoidectomy. But tonsil, in case of in grade 3 tonsil and more, we prefer. Otherwise, if history is there, repeated throat infection, then chance. Otherwise, absolute indication, we prefer the obstruction.
Okay, sir.
Okay, Dr.
Sir,
Ghosh, do you advocate adenoidectomy along with face in a pediatric patient?
Yeah.
Do you advocate?
Oh, no, sir. Sir, I prefer always do adenoidectomy first, and if irrigation clearly, because the lot of patient I am seeing nowadays doing CT scan. In my chamber came, we prefer advise the guardian do adenoidectomy, definitely it will resolve. So it will resolve, question. Oh. So the only adenoid and wait for few months. Sometimes if huge polyp, endoconal polyp is there, then you may remove. Otherwise, if only secretion in the sinus cavity, we prefer the only adenoid surgery and sometimes good wash. we don't prefer the face in one sitting
Okay.
if adenoid is there. Now you see, you
Wha-
definitely appreciate the clearance.
So what is the youngest age in which you are doing an adenoidectomy?
1 year 6 months, and just few days before, one children have 1 year 3 months, 1 year and 3 months, a huge totally block, full adenoid block, and
Sir, we have a patient rate of 1 year, 3 months to up to 64 years.
yes, adult adenoid is the lots because we do the lots of OSS surgery. So adult adenoid routinely, if we do the routine nasal endoscopy, lots of adenoid in case of adult also. So there is a totally.
Sir, also, we like to emphasize there's a difference between once you take up an adult adenoid versus a pediatric adenoid, the consistency of the tissue, the hardness, and because of repeat
Yes.
infections, the kind of surgical time and also the VAN consumption is pretty different in adult versus pediatric or a
Yes.
smaller age group patients.
This is the 9 years of age, but in case of children, it's very soft. In case of adult, 55 years, more than 30 years, huge adenoid. Sometimes I have used also in Dr. Sean also, I have used 2 hands in one adenoid only. So tough adenoid, fibrotic adenoid, difficult, and one consumption is much more.
So also chronic smokers, the kind of fibrosis which you see, and it's really tough to actually take out the adenoid with the wand. The VAN
Yes.
consumption becomes very faster, and the bleed also happens most of the time.
In case of young adults, sometimes we face also, you have seen huge fibrotic adenoid, difficult to do. Then I stamp is the homeopathic adenoid. This is the homeopathic adenoid. Because if parents take the homeopathic medicine, then there is a problem. Sometimes fibrosis is there. Look here, the beautiful, no?
Yes, sir. So we can see the patient.
Perimyxal
Very nice.
Yes. So if some tissue will be there, this will be the basically denatured tissue and all will be exuded. After 2 months now, all will be fibrotic and one scar mark will be there. I think this is sufficient and definitely you will be
Yes, it's a
happy
beautiful plane.
without any
It's
drops of
wonderful
blood, no?
dissection. Yes.
And a boundary. Now see the boundary from up. Okay.
Yes, the choanal part.
Peripheral to Passavant ridge and laterally fossa brachianular to fossa brachianular and anterior also and posteriorly the buccopharyngeal fossa or perimyxal sheath. Okay.
So
Definitely.
would you
and-
remove some tissue near the Passavant's ridge inferolaterally on the left hand side? Near the Passavant's ridge inferolaterally left side, sir. Would you
this.
remove that tissue or would you like to leave that part? Inferolaterally, sir. This part and the other lateral part.
These nothing is there. Basically, this muscle, no, slight bit of bulging, no. But look at the clean.
So does this increase to more slough formation? Because this area is an area of constriction and post-operatively many times
Sometimes
the
if
slough
you do
formation
more,
increases.
then chance of regurgitation more.
Yeah, then
Basically,
the
you see that here, no, this is the
yeah, that's a
Passavant
clean
ridge,
fascia, sir.
clean, no. And here sometimes some due to muscle bulging, you see the clean and
So even if the thin layer of adenoid tissue is there in the Passavant ridge, we
No problem.
deliberately keep it there, sir. Just the reason being that will be sloughed out. Second, if we try to just scrape it out, the chances of the insufficiency, velopharyngeal insufficiency or regurgitation is much more. And the pain during swallowing also sometimes increase. So just we deliberately keep a little bit of tissue there, sir.
but clear basically.
I
and
feel if the patient does not have a history of any insufficiency earlier, there's no cleft palate. And in my practice, I've seen if you have
No,
a clear,
I
nice
remove- I
plane,
remove-
patients do not have chances of insufficiency later on.
No.
I mean,
So if insufficiency, sir, I believe within of 1 month it will be clear. And just I ask the patient just do balloon exercise.
so I feel the
blow
slough
the-
formation
inflate the
becomes
balloon.
much better if that area is in a very nice plane. The slough formation
Yes.
post-operatively is much
Yes.
easier to manage with a wash.
Good was and sufficient.
Yeah, and a spray post-operatively for at least 2-3 months.
Yeah, I will show one another case. So it will be easier, and some doctor if miss any already induced.
Do
So
you have
just,
adult case, Dr. Ghosh?
adult.
Yeah.
Adult cases, I've prepared for 10 cases for today, 10 cases because the backup. By chance, if any 2 cases or 3 cases missed, if
You
fever
have
or turn up,
fibrotic
no.
adenoid case, adult case preferably.
But now in induction adenoid is difficult in adult. Adult tonsil is there. Just I will show the here one another tonsil. So for juniors, idea will be clear. Sometimes some doctors may feel that case was easy, that case is the different.
Sir, one
So if
question,
you
sir.
can show us a intracapsular dissection for the tonsil, that will be
Yes,
good.
yes, yes. I will show the one intracapsular. Okay.
Sir, do you encounter any secondary hemorrhage in any of your patients
Yes, yes,
after?
yes, yes. Yes, second hemorrhage definitely I encounter, but I assure the patient should not worry, should not do any surgery required again. Just conservative medicine, tranexamic acid tablet, good gargling, sometimes antibiotic change and cold water, fridge water. That is sufficient. I tell this is the spotting, not not a secondary hemorrhage with conventional technique. No, there is lots of conventional technique. If you do, then hemorrhage will be sometimes required OT, operation, go the operation theater, but not required here.
Sir, how
Here
many
in this
days?
case, I will show the right-sided extracapsular, left-sided intracapsular.
Yeah,
So,
that will better.
big tonsil, na?
How many
Yeah,
days post-operatively you ask the patient not to indulge in playful activities in a child?
Question কথা বলো না কোশ্চেন শুনতে পাচ্ছি না স্যার রিপিট
Sir, how many days post-operatively you ask the child not to indulge in too much of playful activities as a precaution for avoiding the hemorrhage?
ও না খেলাধুলা স্যার স্পোর্টস অ্যাক্টিভিটি ইফ পেশেন্টস we should allow after 2 days because if patients go outside and normal activity, then complain the pain is less.
So the audience has a question. Apart from bleeding, any other complications have you encountered during your post-operative period in these patients?
Any complication?
Apart from bleeding.
Only sometimes neck pain. That is a counsel already, and our protocol is the printed prescription, printed post-op note is there. Sometimes it may happen. Sometimes throat pain, neck pain, slough, nasal slough, and oral cavity slough. That is the major complication. In case of coblation, major complication is very less. দেখতে পাচ্ছি না
So what I have seen after post-operative 7th to 9th day, patients usually come with a little bit of throat pain post-tonsillectomy. It's typical
Yes,
after 1 week
Due
to
to-
10
due-
days
due to-
after surgery due to
muscles-
little
due
fungal
to muscle
infection.
spasm. No, low grade fever, sir. I feel the one day, first day, 2 days. This is the another microscope. Here, right side I will show the ECT and left side ICT. Okay.
Yes.
So in
So
which
idea will
cases
be-
do you prefer intracapsular?
This case, ECT is better. Basically, exobiotic tonsil. No, look here. If I pull, then pillar, antipillar will be clearly seen. So unnecessary. Why intracapsular? No. If you see, look here. So this pillar will be safe. If here up to here, no, pillar should sacrifice, then intracapsular is better.
Sir, where is your endotracheal tube? One of the question has been asked.
Endotracheal tube. This is
Yes.
the tube. Look here.
Can you
This
just
is the
show it?
tube.
Okay.
Okay.
So is it a south pole tube you're using?
South pole tube.
You have kept the tube in the slotted part of the
Yes,
top.
yes, sir. Look here. This is the tonsil. So my target. Focus karo,
You are going to do intracapsular this time?
This is the ECT. I will show left side. I will show the big exophytic. I will show the ECT, and
Sir,
here
in
I will ICT.
exophytic
Okay.
tonsil, sir, we prefer to do an extracapsular dissection, while in endophytic, where the chances of preservation of the anterior pillar is less, there we prefer to do an intracapsular tonsillectomy due to the pain, sir. If we can preserve the anterior pillar, the pain is
Pillar
relatively
preservation
less
is
in
most
these
important.
patients, sir. So that is that is how we decide what to do.
Okay. Thank you.
Look here. কতটা আছে তোমার ইয়ে? ছয় আছে কি?
So do you get
Magnification?
more recurrence in intracapsular cases compared to the extracapsular ones if
Yes,
you're
yes.
doing is more often in intracapsular?
Extracapsular, sir, extracapsular zero recurrence. Intracapsular definitely less than 1% recurrence chance. In case of young, less than 3 years, better do extracapsular.
Yeah.
In case
True.
of adult, better do intracapsular because the pain will be less, very less
Pain will be less.
intracapsular. In case of children, if you do extracapsular good way, pain is very, very less. Look here, no pain will be there here because the no muscle exposed, no pillar injury. Look here, the posterior antepilar all will be intact. So pain 6 করে দাও তো দাঁড়াও এটা ভুল করেছো তুমি না আমি তো 6 করি না by mistake it was in microscope setting was the 4 magnification, but I prefer the 6 magnification. Okay, now the 6 magnification, look here. Don't pull too much in lower pole, there is a chance of bleeding. Okay, look here, all intact, no? And
So-
if you
so-
I
think
think
the some
there's residual
tissue,
tonsil left.
So what we do is we go intracapsular in the inferior end and we start extracapsular from the superior pole.
this is the mixed way. Sometimes
Yeah,
but
that's
not
where we prevent
purposeful.
injury to tonsillar artery in the inferior pole.
Yes, yes.
Do you
This
take
is
out, do you preferably take out this lingual tonsil at times if it is proliferative?
This is the lingual tonsil. This is the lingual tonsil. This is the.
Yeah.
But here, lower pole, some tissue is there.
Yeah,
I
do you
think.
prefer to take out lingual tonsil routinely?
No, no, no,
If
no,
it
no,
is-
no, 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 not
Not
regularly.
routinely, sir.
Here, I'll show the intracapsular, but it is also big tonsil. Okay, but I'll show the. দাও একবার। This way, look here.
Sir, if you can appreciate
it's
in this
quite
tonsil, it's
intracapsular.
quite endophytic, sir. So
Yeah, it's
preservation of
endophytic.
Yeah.
anterior
So
pillar is
here-
difficult. So the pain score will be more for this patient on this side. That's why we'll prefer doing a intracapsular tonsillectomy.
Here I will show, but one consumption definitely will be more in case of intracapsular. Look here, movement of the intracapsular, this way.
From inferior pole? Okay.
Yeah, this very speed.
We use a cotton patty to put traction so that we don't inadvertently injure that mucosa over the area.
Okay.
এই জল খাচ্ছে না। So oropharyngeal suction tube is the most important. Not look so nice like extracapsular.
So, sir, how do you decide what is the end point first? Suppose usually we don't prefer to direct the wand towards the floor, base of the tonsil. But in this case, we have the wand on a dissection more towards the tonsillar base. So when do we
No,
decide that we have to slow down?
I will show the how I will manage. I ask the junior how manage, how avoid any injury. Okay, now first debulking with this area. Debulking, now debulking, doing debulking. Look here, debulking. So all are under control. Look here, the pillar.
Yes, sir.
When I reach there, then I change the direction. Okay. Now just only debulking. Intercapsular pain is very less because the no muscle exposure, slough is less. This is the look here. This is the capsule. Okay.
Yes, sir.
So we encounter the capsule for the first time near the posterior pillar. So that
Yes.
serves as a guiding point for the depth of the dissection.
Okay.
Now you see, here all are now controlled. Now direction. Look here, my direction of the wand. Now change of direction because I am reaching the capsule area.
Capsule of the tonsil.
Yes. Now direction change.
What is the mode of setting in intracapsular dissection? Same?
Settings are 9.5.
Same setting. I always with coblation always 9.5. Sometimes here there is a chance of bleeding if
Yeah,
you
because the tonsil artery usually comes in this area.
yes if you not careful. This is the capsule. Look here the
Yes.
capsule.
Yeah, we can see the capsule.
So slight bit of tissue if you kept, no problem, because all will be slough and dead tissue will be there. Except ECT more lucrative. ICT not so lucrative to see. This slight bit of tissue. So change of direction. Now my one movement is very slow because otherwise sometimes there is a chance of injury of the capsule and you will go the muscle. Okay. So this is my limitation now. So I think it is the very good
How to
clearance.
differentiate the capsule and muscle in a
Look
jab
here.
tissue?
Yes.
Just magnification. Look.
So there's
the
some
capsule?
tissue.
Yeah, this is
The capsule and slight bit of tissue, no? Here, that tissue, no problem, because the over adenoid also, when I will see the buccopharyngeal fascia or perimyxil, some tissue will be there, because the all will be exuded, no? So this is the sufficient, basically.
So there's
This is
some
a
tissue
sufficient.
at
Look here.
12 o'clock position. Would you keep this tonsillar residue on the
This
12 o'clock?
this
No, sir.
area.
Superior, on the near the inferior pole, little up. Yeah, this
Yes,
tissue.
yes.
Yeah, this red one.
This is the
This is
the
the
lingual
tonsil.
tonsil. Okay. Just. Right,
Yeah, that
right.
one. Right.
Jalvara.
So I wanted to ask you if we are able to take out the endophytic tonsil, would it be better than leaving this tissue and a chance of recurrence later on versus taking out with the extracapsular in case we are able to take out the entire one?
Question.
I was asked if we are able
just-
to do a extracapsular in a endophytic tonsil vis-a-vis intracapsular. So
No.
which one should be preferred? Because this might
no,
give us a
basically,
recurrence.
The exophytic is the clearance 100%.
Yeah,
possible.
100%. That's easy.
In endophytic, sometimes 5% tissue will be there, but that not create some problem sometimes. But sometimes I have seen also after ICT, sometimes some bits of tissue is there, hypertrophic, but no harm basically, no. Already debulk, grade 1 tonsil. If grade 1 tonsil, then is the no problem sometimes. In case of OSS surgery, we are doing no intracapsular. So sometimes some hypertrophy tissue will be there, but no harm. So if you are interested, my opinion, my vast experience, because I am doing lots of tonsil adenoid. Today I will do 10 cases. So lots of adenoid tonsil. So my experience, recurrence is very less in ECT. And believe me, if ICT also, recurrence will be there, but no harm. You ask or convince the party, if I do ICT, pain will be less. Secondary hemorrhage will be very, very less. Sometimes there will be some tissue, but no harm at all later on. That is my counseling to the parents.
Okay.
If I have time, then I will show the again one adenoid. This case also adenoid is there. Down.
Yes, sir.
And otherwise, if time.
Dr. Ghosh,
Yes, sir, no problem.
10:30, that other patient is already on the table.
Yes.
We had told them 10:30, so they will be ready to start. If your patient is
Okay,
already.
so 10:30, up to 10:30, I will demonstrate. I am facing question, and 10:30, 10:15 now.
Yeah.
So I am ready to up to 10:30, then I will leave, no problem. Now
So you've got the next patient already under anesthesia induced?
No, this patient already, this patient tonsillectomy done. This patient already, I will do the adenoid.
Oh, yes, please go ahead. Please, of course.
Yeah.
I thought you wanted to do one more.
Oh, no. This.
Out of the 10. So
also. Sir, would you
but it's amazing what
yes,
you have
amazing dissection. Beautiful.
Absolutely.
A big round of applause for Dr. Khan, please.
No, thank you.
You can hear that applause. We are all fascinated by your technique. Absolutely fantastic.
And sir, speed also.
Yeah.
No,
Speed with the finesse.
So your 10 tonsils you'll finish by lunchtime.
Yes. No, basically today why 10? Because the backup.
Yes,
By
I
chance,
know.
if some cases not turn up, some fever or some problem. No, I was I was the Canada for 10 days. Last one day before I returned. So before that, I prepare at least 10 cases. Some patients will be, if gone, then no problem at all. At least 5 cases will become.
So would you like also to show us the change in position which you do once you switch from tonsillectomy to adenoid in terms of neck movement and the head position which we change?
Head position in tonsil.
Sir, we remove the sandbag that we use for tonsil. So the neck extension we removed, and then we use a palate retraction for this case. Then we come to the right side of the patient. We bend the wand and then rest. Sir will show you.
Yeah.
That's all. Nothing else.
Prepare with the nasal drop. Look here, stroke. For
No, show us the endoscopy picture, please.
Yeah, endoscopy picture.
Yeah, okay, we are there with you.
Yeah. Upper pole. Ready? Now ready? Look here for junior, the speed. Speed is very important because I don't prefer any block of the vein. No, sometimes a block is create the problem. So, and strokes, look here. The movement of the vein. And some doctors are against the coblation. They told lots of time required, but I don't believe. Why unnecessary time? No. Time is very less because no second look required. In any technique, lots of time required the second look.
So your movement is just side to side or?
Yes. This way first, this way, then does this way. Okay. Stroke this way.
It's just like a wiper movement, sir, like car wiper. We will always keep the wand superficial. We should not insert deep into it.
Ground electrode, the white portion always under vision.
Also,
if you go this way, there is a bleeding.
Do you do interrupted band usage or it's a continuous pressing on the pedal while you're?
Continuous, but sometimes interruption definitely.
Yeah.
In tonsil interruption, but here to normally continuous.
Okay.
For the irrigation we use, sir, we use the pneumatic cuff to increase the pressure of the water
true.
inflow.
Yeah.
So that there will be a no blockage or a
Sufficient
minimal
flow.
blockage.
So, sir, do you also push the saline from the nose additionally while you're working through the endoscope?
The endoscope. It's,
No, not
Okay.
at all.
Okay.
Look here, this is the fossa abdominal area. So press and move, press and move. ছবিটা ওখানে তুলে রাখলে দেখি ওখানে যেটা ছবি আমরা পিকচারটা টিভি থেকে তুলে রাখুন
when you say press and move, in what direction are you giving the pressure?
Yeah, oh, and not pressure. Basically,
No, you said
I'm
press
using
and
the
press and move.
plasma. Look here, I am slowly now slow motion. Look here. I am using the plasma. And again, I will show the slow motion. Look here.
So we just hover the blade, basically. It's like hovering effect. A little bit of touch.
Now the passament ridge. Look here.
So in cases of patients with septal deviations, do you manage this surgery along with septoplasty or you stage your cases like
No,
doing?
no, septoplasty. I counsel septoplasty. If required, do septoplasty, but PAG required. I counsel the patient. In case of less than 5 years, I avoid. But more than 5 years, I do the septoplasty in a same sitting. But I counsel the patient.
The question for you, Dr. Ghosh, is in the torus tuberous area.
Yes, sir.
On the torus, how do you make sure you do not injure the cartilage in that area?
Not injury. Look here, sir. This is the instrument tube. Okay. So a lot of gap is there, and cartilage will be there here. So I am using only soft tissue. If required, I just remove the soft tissue. In case of adult, no, we are removing that part. So no problem, because if you keep that part only, then it's sufficient. The tube injury. If you do this way work here, then tube injury. Otherwise, no problem.
So we keep the wand medially, sir, and just the medial 1/3 we just removed. Only the soft tissue part. We don't press or go deep into it.
And how I'll remove the fossa abdominal area? Look here. Press and tissue will come. Press and tissue will come and move.
Okay.
Press and move. Press and move. Press and move. If I do this way, then some hidden part will be there. The bleeding will be there. Okay, then problem. So press and move.
So you press it to get the tissue.
Otherwise, you just take the angle endoscope. Then is the problem, but here sufficient. I have an angle pediatric endoscope. These are all are pediatric endoscope basically. I am using this pediatric endoscope, 2.7 mm.
Sir, you use angled endoscope also sometimes if you don't see the blind spot of the fossa abdominal.
Angle endoscope.
Yeah, do you use sometimes?
Very rare. One angle endoscope is there to prevent sometimes any problem, in advertent problem, by chance bleeding. Then, but normally not required too much.
Sir, your movement is side to side sweeping movement, right? Sir,
Yes.
what about up and down movement? Like the one
Up and down
directed
movement,
up?
sometimes this way.
That
But if
way?
you do this way, no, sometimes you will go the inside, there is a chance of bleeding. My all juniors started sometimes, then they face the problem. So, but if you do this way, this is a very safe technique. I'll show again this part. Look here. Now, look here. My movement. This way, slow motion. Now slow motion. Now speed. Look here.
You are like a magician.
Here there is a chance of bleeding just posterior part of the septum area. Some pain will be there. You just sit carefully. This movement, look here. And all times my ground electrode under vision. So no obstruction, no bleeding, no unnecessary bleeding. So definitely I will finish before 10:30. Okay. So I will
The
finish.
speed at which you're going, I think you can do one more case.
Thank you, sir.
It's a pleasure watching you.
Thank you, sir, so much giving me this opportunity. I am so lucky feeling. Today I feel lucky. You
Like I
contact
said,
me.
there are 30 medical colleges students observing you, so I think it's a big inspiration for them as well.
Yes, sir. Thank you so much for giving me this opportunity. Now you should slow because the perimycal
Absolutely.
sheath is there. Okay. So now speed, check speed. If sometimes foggy, so my assistant irrigate.
Yeah.
Joel. Okay. Ready? Now Joel Asen. Ready? Oh, God. Now look here.
Yeah, that's the
Beautiful.
patient. Very nice to see.
You can see the
Yes,
fascia
yes.
clearly,
Yeah.
yes.
There is one question, why there is a neck
This
pain?
is the passability, okay?
Yeah.
Why there is a neck pain after adenoid removal post-surgery?
কি বলছে কোশ্চেন শুনতে পাচ্ছি না
Sir, please repeat the question, sir.
There is a question, why there is a neck pain after adenoid removal post-surgery?
neck pain
Yes.
because the muscle spasm here, the muscle spasm is there. One sign is there, Grenard syndrome. The neck pain due to muscle spasm, basically secretion, slab, and then if you remove much more and also muscle exposed, then much more neck pain. If you keep some tissue above the perimycal sheath, then pain will be less. And if you expose the muscle, then pain will be much more. So you should know the proper plane. Look here.
Yeah, that's the patient, right, sir.
So there is one more question. Have you have any experience of bonds, or are they better than Smith and Nephew?
Yeah.
Bonds band.
Now, basically, bones is there, but I am purchasing the lots of adenoids, so don't mind. I have purchased the 100 once each time, so they give me offer. So I don't prefer other one. Benefits I have tried, but not so much happy.
So have you
because
used, do you use Precise Max sometimes when it's a very massive?
No,
adenoid,
initial life
or-
I have used the Precise Max for adenoid surgery because at the time I struggled few days, initial life, but I am not comfortable with the, in angioplasty also I am using the same one. Every nasal case I am not purchasing any Precise Max, only EVAC I think is sufficient for me, any nasal cases.
Okay.
Larynx, okay. And you, for juniors, you should check all time after adenoid surgery also, there any
Yeah, the fossa should
bleeding.
be checked.
Yes, yes. So that is now question, and definitely you are happy after saying
We are
Very, very
adenoid
beautiful
tonsil-
dissection, sir. Very
Also,
beautiful
I think
dissection.
we are absolutely fascinated with your technique. Thank you so
Thank you,
much, and you can hear
Thank you.
Thank you so much for giving me this opportunity, sir. Thanks again.
Thank you, sir. Now I request Mr. Rajneesh to please come ahead on the stage and please felicitate our moderators for this surgery. Request, thank you, Ghosh sir.
Yes, sir.
Dr. Ankur Gupta.
Hello. Abhi, just go back.
I request Kirtani sir to please join for felicitation.
नहीं अभी ठहर जाओ, वो he has to start. वहां से ना नहीं अच्छा अच्छा कैमरा उधर है, ठीक है.
I request Kirtane sir and Mr. Rajneesh to please felicitate Mr. Dr. Rajat Bhatia. Next, I call upon Dr. Monica Karam. I call upon Dr. Khageshwar Raut.
2 मिनट बैठ जाऊंगा यार. Thanks.
Thank you, sir. Thank you to Dr. T.K. Ghosh and all the moderators. Thank you so much for moderating this surgery. Now we move on to the next surgery by Dr. Devendra Rai. It will be endoscopic DCR. And for this surgery, I request Dr. Narendra Verma to please come ahead for moderating the surgery. I request Nitish sir to please welcome Dr. Narendra Verma. Dr. Deepak Dalmia. And I request Dr. Ashok Bhandari to please join for moderation. Yes.
Start sir. Thank
you, sir. Thank you so much. With this, I request Kirtani sir to please take over.
Hello, Devinder, can you hear us?
Yes, sir. A very, very big hi.
A big hi to you and thank you for accepting our invitation to show
Of course, sir. A big privilege. And thank you again, sir.
We have your slide on the screen. I think
Yes.
somebody was going to tell us a little bit about the history.
Yes, sir. Dr. Arpan?
Good morning, everyone. So this is a case, a 79-year-old female presented with excessive watering as well as frequent episodes of purulent discharge from her left eye for past 1 year, for which she has been treated with topical antibiotic eye drops intermittently, but her symptoms did not improve. She has a history of cataract surgery in the same eye 2 years back. She gives no history of any ocular trauma, nasal problem, or redness, or any visual disturbance of late. She is known hypertensive and has been taking antihypertensive medication for last 20 years. There is no known comorbidity other than hypertension, and there is no known drug of allergy. Next. On local examination, the eyelids were normal on both sides. The eyelashes on the left side were matted. Lid margin was normal on both sides. Punctum were normal in position on both sides. The lacus lacrimalis on the left side was filled with water. On diagnostic nasal endoscopy, there was high up DNS on the left side and a small posterior septal spur, but the axilla was free and there was no other abnormal growth or polyp. On palpation, the temperature was normal. There was tenderness present over the left lacrimal sac area. Regurgitation on pressure over lacrimal sac area was positive on left side. Some purulent discharge came out. On lacrimal probing, there was hot stop felt on both sides. On lacrimal syringing, on left side, there was purulent discharge coming through the upper punctum, indicating block in the nasolacrimal duct. The right side was normal. This is the coronal view NCCT PNS. Here we can see the some left side DNS, and but the middle turbinate and axilla were free. On axial view, we can appreciate the distended left lacrimal sac area on the left side. On routine pre-op investigations, all the routine baseline investigations were within normal limits. ECG was normal size 7. Medicine and cardiology clearance has been taken in view of her age and long-standing history of hypertension. A pre-anesthesia checkup was cleared and she was declared fit for surgery. Now she has been posted for endoscopic dacrocystal rhinostomy on the left side. Thank you.
Thank you, Dr. Arpan. And yes. So do we have the picture at your end?
Right. We can see you. Now we can have the endoscopy picture.
Right, sir. Just want to tell you that as Dr. Arpan had mentioned, there was a bit of a septal spur, so he corrected it before we started surgery.
Okay.
So that access is a bit better, even though it was not bad. And now I am going to show the endoscopy picture with elevator. Now we can see we're just going through the anatomy. A bit of septal spur is there, but it's posterior. I didn't want to touch that. And it was here that we have better access now. Middle terminate, and you can see the middle terminate is basically the landmark for the sac itself. Anterior, superior, and a bit inferior is where the sac lies. And this is the maxillary line which comes out from the axilla, and here is the prominence, and then it goes under the inferior terminate, then goes towards the Hasner's valve. So here it is. So there's no discharge which can be seen. Right. Ansonate process over here, ethmoidal infundibulum. And so that is the basic landmark. Pure LV.
Sir, good morning. Good morning. I am Dr. Dalmia, sir. Nice seeing you, sir.
Yes.
Yes.
Hi.
Sir, actually, you said that you removed the spur, but you took the care to remove the spur from the opposite side to avoid that is.
No, I didn't remove the spur. I left it because it's posterior, but there was a higher DNS, which was frankly not covering the axilla so much as Dr. Arpan had very rightly said. But for, let's say, purpose of demonstration, I felt it's better to remove that much of visual impairment so that we can go with a better presentation.
Yeah, but you try to remove that from the opposite side to avoid.
From the opposite side, so that we don't have blood smudging over. Otherwise, the endoscope gets smudged. And then why have that? Why not just do it from the opposite side?
Yeah. Is there any role of dacryocystograms in your books?
Actually, we do it, but in this lady, actually, there's a mucocele. And after the probing and syringing, the whole thing is so clear that we didn't do a DCG. Otherwise, I had two patients who had undergone a DCG because I was preparing for this. One of the ladies, I mean, the dye just passed through and we didn't keep her for surgery. The other is, I think about 18-year-old, but her hemoglobin is only 6.6. So I couldn't place her for surgery also. In this lady, because it was a mucocele or a cystocele, you might say, I felt that is not a real requirement for a DCG.
Yes, sir.
Good morning, Dr. Rai. I am Dr. Narendra Verma from Ludhiana, Apollo Hospital. It's
Haan ji,
always
hi.
a treat to watch you, sir, doing
No,
this kind of, you see a master doing a job. It is always a treat to watch you.
No,
And
thank you so much.
it is a source of encouragement to all of us.
Dr.
The things
Narendra,
are so crystal clear.
thank you so much. So now, see, what happens is we need to expose the lacrimal sac. Covering up the lacrimal sac are two things. One is a mucosal covering, and the other is the bone itself. So each and everything needs to be planned properly. Why the mucosal one? Because that leads to the other level or area that is a bone. So it should be very made clear as to how to, first of all, plan the incision. The planning is, first of all, it's anterior, and second is axilla. The axilla and approximately 8 mm above is where we place the first incision so that we can expose the frontal nasal process of the maxilla. Idea is ultimately to expose as much of the fundus of the lacrimal sac as is possible. As we know that the fundus lies approximately 3 to 5 millimeter above the axilla. So we just go 8 millimeter approximately and then make an incision which is vertical. Second incision lies again anterior to the middle turbinate, and this goes a bit below, maybe about a millimeter or two, just below the level of the middle turbinate, because the sac again goes slightly below. And then is the maxillary line. The maxillary line is where the NLD surface mark is there. So in that, we go at least a centimeter away from it and then make it, but nowadays we are giving a slightly longer incision so that we have more of bone which is exposed. So if there's a drilling required, the drilling is better than, rather than having mucosa around it. Now, I'll ask for the knife. Knife, please. This is a 15-blade knife.
You give infiltration, sir, in the mucosa.
Sorry, my fault. I should have just mentioned to you that we have given the infiltration in, I think Dr. Ghosh did such a marvelous job. I didn't expect that he'll do so many surgeries in this short time. So I thought I'll prepare myself, and the preparation, I did everything. Did the septoplasty, limited of course, and gave the incision, the local also.
Okay. Ready-made 2% xylocaine with adrenaline.
Ready-made.
Yeah.
So here is the first incision, just a bit below, and there it is. It should go bone deep, right above the inferior turbinate. So this is the first incision, and we give it beyond the maxillary line and go up to nearly a centimeter or more, even a centimeter and a half. So that's the first incision. The second is, of course, above the axilla. And this almost parallel to the first incision. Again, it goes bone deep. And after that, once it comes out here, we ensure that it doesn't reach up to the piriform aperture, right? Because if it does, you're walking into the vestibule and you can have some stenosis later. So now we have these two incisions, which are nice and wide, and then we join them. Again, bone deep, and I'm joining the reason why I've taken the inferior incision first is because bleeding is there, and let the bleeding go by gravity. And here it is. When you join, of course, you have to release it properly. Now give me the elevator. Using a Freer's elevator. So this is the mucoperiosteum layer, which is based, it's a flap basically, based posteriorly. Because when we are going to complete the surgery, as in all nasal surgery and probably in the ear and everywhere, the mucosa is a very important thing to preserve. Suction elevator. Here it is being elevated. And you can see the bone coming in.
Yes.
Which is a frontal nasal process basically. I'm going below, up. Idea is to keep on elevating it with the periosteum. It should be like that. Give me a small pack. It's going to give me the pure adenine packs. Pure adenine. Now, initially I was using the xylocaine with ADR, which was 1 in 5. And now I'm using a pure adenine pack. Of course, with permission of the anesthetist. Is giving good hypertensive anesthesia, and blood pressure is 67 by 38.
Heart rate is 57.
And the heart rate is 57.
Good. Big salute to anesthetist also.
Yes. I think it's a teamwork, and I think every one of us realizes the importance of the anesthetist, and a good anesthetist at that, who understands you and you are in absolute tandem with that person, only then works out as a good team.
Indeed. True.
Hello.
Hello.
Dr. Devender. I'm Dr.
Yes.
A.K. Bhandari from Amritsar.
Ah,
Sir,
Dr. Saab.
have you ever seen that the incidence for the chronic dactylocystitis is much more in the noses where the nasal mucosa is atrophic and dry nasal mucosa?
Yes, we have seen it quite often, and this is one of the reasons why we have this problem, because the nasal mucosa is not limited to just that area. It is also limited to the fact that the Hazener valve is there, where dryness and all that atrophic changes can lead to secondary inflammation and subsequent fibrosis. Scissors.
Sir, could this be the reason in this case also which we are operating upon? Because otherwise there was no any kind of thing, no trauma as the history had told or something. Possibility of DCR at this age is possibly, could this be because of this dryness and atrophic changes into that particular area?
See, As far as the causes of chronic diabetic cystitis is concerned, right? The acquired ones, which in this lady she has, the primary acquired ones are mainly in women postmenopausal, average age being about 67 years of age, is generally because of the hormonal problems. So this is not because of the atrophic changes. Sometimes the predisposing factors are even the postmenopausal, the hormonal changes, and sometimes even this, the DNS also can cause a bit of inflammation. Now I'm just draping this over the middle terminate, so we take it away from our picture, from our, yeah.
Yeah, vision.
Even the uncinate is visible now.
Yeah, now you're seeing the uncinate also, you know? So here it is, the maxillary line, and we got our area quite free just for.
Sir, actually, 250 delegates are seeing you, and as Dr. Kirtanes has said, it is telecast going on in 30 medical colleges. The
Amazing.
questions are coming from the audience. One
Yeah.
question is use of collar-head needle for incision.
You can use it. It's one of the good ways of giving the flap so the bleeding is less. But you see what happens is we use as many instruments which are, I mean, you can keep on adding instruments, but use one which is a bare minimum and which you can get away with. Now, to my mind, the bare minimum is a kerosene punch, and today I would also recommend the microdebrider with the burr, so that in case you have a very hard bone, let's see, because people of this age sometimes can have hard bone. So let's see if it is really hard or not. No, the kerosene punch.
Devinder sir, suppose if you get a case where the medial maxillectomy, hello.
Sorry, yeah.
If you get a case of where the medial maxillectomy has been done and there is secondary epiphora, the patient presents with the epiphora after that, and there is injury of the nasolacrimal duct probably.
Yeah.
So the approach will be the same, or you'll differ your approach, you'll modify your
No,
approach?
it's just the same, because there the nasolacrimal duct has been damaged, right? So it is basically an NLD block because of trauma. Iatrogenic, yes, but there's still trauma only. So it will remain the same. The approach is just the same. Because
And
sac is...
The size of the mucosal flap also will be the same, or you will prefer to take the flap in the upper part only, the lacrimal sac area?
See, you can modify it according to what you get. The idea should be to literally expose the sac properly and then address the bone, which is still, the frontonasal process is still there. Maybe even the lacrimal process may still be there. It all depends on how aggressive it has been. But you have to take out the bone, reach to the sac, and marsupialize it.
And what will be the appropriate investigation we should do in that case to see what will be the appropriate investigation prior to the surgery in that case where the maxillectomy has been done?
DCG. And preferably a CT scan DCG.
Thank you, sir. So this is 1 millimeter crisis, sir?
Yeah. Just, yeah. 2 mm dollar there. It's too thin. This is, we're going to use a 2 mm one, which I think at the moment is better.
Yes, yes. And sir, in post-traumatic cases, road traffic accident or the facial-maxillary trauma, how you manage? Because it is a difficult situation, you know.
Post-traumatic, again, you have to get a DCG done. You have to get a full CT scan. And when you see it, at times, you will naturally take the help of the eye people also at times. And you will probably put in a stent also, which we generally don't tend to put. If
Yes.
the sac is easily seen because of the DCG and all that, then you may go through it like any normal thing, unless until the fracture line is there. See, those are slightly variations which you have to adopt according to what you get.
Yes, sir.
You know? Now here where I'm punching, you see what I'm doing. You see, this is the, you can see now the
Yes,
NLD
yes.
coming in, right?
Yes, yes.
So I'm just using the Kelsen punch and going as much as anteriorly as is possible. Here you have to just reflect the lacrimal sac or the NLD backward, sort of retract it with the help of the Kelsen punch, and then work yourself and then release it so that it doesn't get impinged into it, and then remove the bone. Sometimes when you do it straight on, then you can have the lacrimal duct or the sac getting entangled into the punch, and then you injure it.
Yes.
So here it is. Okay. What I'm doing now is removing the frontonasal process. Now we know that the lacrimal sac is housed in two bones, the frontonasal process and the lacrimal bone.
Yes.
The lacrimal bone is a bit thin, and the frontonasal, of course, is thick.
Yes.
But if you want to place the anterior flap, we have to have as wide of an opening as is possible, anteriorly especially, because that's where the sac is going to lie.
Dr. Rai,
Yeah.
sometimes you, do you think of using a drill instead of this?
Yeah.
I mean, the
No, not
stop
instead.
is-
See, what happens is we use the punch as much
Yeah.
as possible, and then
Yeah.
if required, we use a drill. At the moment, I think it's going
I
okay.
think the first point is definitely, no, it's so clear, so good. But I was just, where do you think of using
See,
drill instead of this?
The top part, if it is thick, as I keep on working, and then I see if the thickness is coming in, I'm unable to do it with the kerosene. That's the time I like to switch over to the drill. And that's the reason why I said, I think Dr. Dalmia was asking me that question, the instrumentation, I think.
Yes, sir.
So I said the instruments basically should be to open up the bone is the kerosene punch and the microdebrider drill, that is the burr.
How you decide how much anterior you go by seeing the sac wall or
the feel?
Okay.
See, now here I'm feeling also. Now, what I'm doing is maximum amount is there. Now, when I cannot do more, that's the time I think I've reached. See, you see, my working is basically anteriorly.
Yes.
This is a bit of a
Exactly where you get a good view of that. There
Yeah.
you particularly, you will leave it?
दूसरा देंगे ना देखो उसको हाँ okay, maybe this yeah, this is a better one.
Yes.
I mean, this is getting a better grip.
Yes.
So now you see, again, I'm working on the anterior aspect. Anteriorly and going superiorly. Okay, now we'll just check.
Yes.
You can see that
Yes.
Indentation.
No, but it's still till the NLD. You think this is dilated NLD? No.
No, this is basically the junction of the sac with the NLD.
Okay.
The sac will be the fundus here. Sorry, I should have just cleaned this. See the sac, the fundus would be approximately here.
Yeah.
Right?
That's
And
right.
the sac is approximately 12 to 15 mm. So here would be a junction of the NLD with the sac itself.
With the sac. Achha, so
This is NLD. You can see that.
Yes.
Yes.
You can see the NLD here. You can see a part of the lacrimal bone here.
That's
a
right.
thin one. Take it up. And this is the junction. Now I'm going upward. So maybe
there's the lower half of the lacrimal sac, which we are seeing at present, right?
that's true. Thank you. Perfect. Okay, just give me the drill. No,
Very nice. Very
because
nice. I'm going to compliment you again. It's a wonderful, it's treat to watch.
Thank you again. And now I'm going to use a drill. This is a rough diamond drill, 2.5 mm diameter, and it is at an angle of 25 degrees, metronic. So here is it has the water, everything. It doesn't have the speed of a skull base surgical drill, but I think this much is good now. So here I am drilling now. And of course, this is the part where one has to reach up. So I'm thinning it out first.
Yeah.
Then I'll use a kerosene punch when it's thrilled out. Because if we keep on using and you reach the lacrimal sac, though if you have a light touch, then it doesn't really injure the lacrimal sac, but you never know when your touch changes slightly.
So that was the reason that you use the diamond drill?
Yeah, that's the reason why, not a cutting one.
Have you ever used the chisel and hammer, sir?
Yes. When we started doing the DCRs, that was, I think, in the late 1990s.
Yes.
Then we used to just take out the mucosa, expose, and then use the chisel. And used to work also.
Yes.
Okay.
Just one tip I can say, if you don't have this burr,
Yeah.
this Zomed, and what you can use normal, putting ear speculum in the nostril and just putting the burr through the ear speculum and scope outside the ear speculum. So it will not traumatize the vestibular.
Yeah,
This
that thing
just
is a good way, of course.
Yeah. Means
So
if
now
you don't have, no doubt you can't replace this, but if you don't have and if you want to use the burr, then the normal burr you can use if you don't have the Zomed one or.
Right. So here's the bone being removed. Because it could be thinned out and therefore it could be taken out.
Yes. Excellent, sir.
So
complete sac is visible now.
now,
Almost.
we can see the sac. And now
Yes.
we work at the lacrimal bone. Now,
I am sure the uncinate is still intact.
yes, sir, it is. Why remove the uncinate?
No.
But initially, when we were doing that, I swear, we used to remove the uncinate every time.
Yes.
Because we have evolved a lot with the times and of course with the expertise which has been there. And it's a very good technique, as was expostulated by Dr. Womald. I think Womald has actually revolutionized a lot of things, and this is one of them. Well, he popularized the posterior plaque technique. We also learned.
Very nice.
Now, drill again.
This is a straight, sir, straight diamond.
No, this is
15 degree.
this is 25-degree.
Okay.
2.5 mm Metronics.
Okay. This part removal is so important to get full exposure of the fundus and above
yes.
the fundus, above
Above the
fundus. Yeah.
True.
Above the common canaliculi. Yeah.
Yes. So that's where the drill is important.
Yes, yes.
Okay. Now just give me a ballpoint.
What is this tissue, sir?
This is a mucosa only. And this will be where the agonisa is there. But I just want to remove this part of the bone first to go to that area.
Sometimes you start seeing the frontal recess.
Yes.
Occasionally, occasionally.
Oh, this is weak.
Sorry? Hanji? Clean. Okay. You tell me whenever it is, you know what happens. So maybe because of the time factor, I'm going a bit more aggressive. I think this should be good enough as a superior aspect concerned. And now I'll just move this part here. Elevator. So there we are. Garrison punch. वो टेढ़ा वाला है DCR punch वाला एक मिनट ठहरा. Let me see. Okay, I think this is good enough. There, दूसरा. We just using a bit of a different punch, TCA punch, the curved one. I'm unable to see because I can't help it. It's really high. And there it is.
These two only solutions, yeah. Sir, one question from the audience. Can we remove bone with cautery?
Bone with cautery?
Yeah.
No, yeah.
This is the question.
No, no. See, now we can see the fundus here. See this?
Yeah.
This is a bit bony here, but let me remove this part.
Nee, would you like to remove this, the kind of the thin bone which is there now?
Yeah, that's what I'm. See, first of all, let me just concentrate on this fundus bit.
Okay.
And then we remove this part. You know?
That's right.
Because it's better to concentrate on one area first. Oops.
This is maxillary process of frontal bone, sir?
And the frontal nasal process, yes. You might say almost. Here it is.
You do this part in all your cases?
Yeah, we should.
Okay.
Now, just give me. No, J correct.
So what is the advantage of?
Advantage is you actually see the idea is to expose. In every surgery that we do, the idea is first to expose everything.
Yeah.
Now, where am I going? I'm basically going towards the agonali here.
Yeah.
Right? Now,
That's right.
this won't be exposed if I had not removed this part of the bone. The bone was hanging out here. Right?
That's right.
Forceps straight.
This is frontal.
Now we're getting this. Yeah. Now, sorry. Now we'll remove the soft tissue we can use with the microbiota also. And you can see now the lacrimal bone.
Yes.
That's right.
Lacrimal bone, that is the posterior part of the covering of the lacrimal sac.
Yes.
Right? And this will join towards the lamina papyracea. So we have a frontal sinus exposure, and here was the small agonizai. So here it is. Now I can use the microbiota also. Microbiota de there. That's good enough. Actually, हो गया ऐसे तो. Okay. Microbiota straight. यार बस ठीक तो है.
You use throughout the surgery 0-degree scope, sir?
See, we can use the 30 also. I've kept the 30, but I'm basically more comfortable with the 0 degree. So I still prefer. Of course, in certain areas we do have to use. Okay. So, and just give me the elevator. Fine. So now we've got the whole sac in view.
Yes.
My
Excellent.
next step would be just give me a pack. I'm going to incise the sac after this. DCR वाला हो गया ना, that knife keratome.
Here the sac is bulging, means we
It's
know
bulging.
mucoid or purulent may be there. But
See,
suppose it is not so bulging or fibrous,
see, I've
then
requested
will yeah. So will you
I've-
use this cannula from the punctum to tent
yes,
it? Okay.
yes. See, now I had requested Dr. Gurpreet also to be with me because he's an eye surgeon. So he is there, washed up. But I think we'll just go ahead because in case I definitely needed him, I would have done that.
Yes.
So we prepared everything, but I think we can go ahead with making an incision.
Yes.
Okay.
So before leaving incision, would you like to infiltrate, sir?
Initially we used to do it, but I don't
Okay.
because it used to become very thick at times.
Yes, sir.
So you base a bit more posteriorly.
This is which instrument, sir?
It's a keratome, I think.
Okay.
So now this is the periosteum. I only made a periosteal incision at this time.
Yes.
Yeah. Now here is the sac, right?
Yes. Yes.
So I now make an incision here. मुझे knife दे दें दूसरा 15 blade. New वाला.
And any reason you give this incision from below upward?
See, the bit of a baggage I carry with certain things. And the thing was, initially we used to always do this periosteum elevation. So I'm actually still going at, maybe not, doesn't give much of an advantage, but I still do it.
Yeah. Yeah. The advantage actually is if you give from below and the purulent discharge starts coming, it will trickle down only. If we start from above, then we will not be able to see that lower area.
Yeah.
Probably when you go from below upwards, what we are
Below
doing,
upward?
everything is under vision, 100%.
Yes. Yes. So now we have inside the sac, as we can see. I'm now widening it. Section. You can see the sac now opened up.
Okay. So would you like to send this for culture sensitivity or you just, because it is the retained purulent secretion, you avoid that?
Actually, it's a very open and shut case. It's not something which we need to do more than this. Just martial price, this is the posterior cuts, superiorly and inferiorly. And you can see that as the flap going back.
Yes.
Now this is the anterior part. Now give me the ball probe. Now this is the area, right? We need to incise it here and there.
Yes.
मुझे ना वो 1 millimeter kerosene punch दें.
Yes.
Sir, will it not be better if we give incision and more anteriorly so that the anterior lip is very small and it is flushed with the nasal mucosa and the
Yeah.
posterior lip is bigger so that it is easy to spread it over?
See, I agree what you say. See what happens when you're operating now, many things happen.
Yes, you're right.
And sometimes you can't judge it so much.
Yes.
So I agree what
But
you say. And yet, this is also good.
this is one of the best instrument to give this incision in the anterior flap.
Yeah.
1 millimeter carisons. Yes.
Yes. इसमें ना 30 degree लगा दो. Now I'll put that 30 because it'll be better to visualize this anterior lip.
Yes.
Maybe see that. And Kelson punch.
So can we use microdebrider here?
One can, but then you sacrifice the whole flap. We used to do that also. But now I think Wormald's technique is being followed more or less by everyone. I think that giving good results and frankly better satisfaction also. Will you throw a sickle knife there? Now see, this is still draping up, right? Now
Yes.
I can, and here where the common canalicular is. Can you see that? I just
If
make
you
this. These are
please-
the.
Sir,
Yeah.
please irrigate this area, then the
We
picture
are just
will
going to do that also.
Yes.
Definitely. I thought I'll just open up still further. Chief, I'll ask you to irrigate. Syringing करना आएगा. कोई और नहीं सिकल नाइफ या वो 11 नंबर नहीं सिकल नाइफ या फिर नंबर 12 ब्लेड दे दो आप. I'm using a different blade for this area because the sickle knife not cutting too well.
Yes.
Number 12 blade, really curved. This is fine. Suppose you cannot do, then you make
Multiple
multiple incisions so that it can drape, because sometimes the surface tension and the pull of the mucosa is such that it doesn't. Now I'll request Dr. Gurpreet, please, Chief, can you just do the
Yes,
syringe?
excellent, sir.
मैं लाइट देना एक सेकेंड.
Sir, at this age, any role of pumping action of orbicularis oculi muscle?
Yeah,
because
we
of
make the person exercise after this.
Okay.
And I'm happy that we don't do external DFIAs so much.
Yes.
And we're more into this. Okay, एक मिनट है ना. एक सेकंड है. चला गया. Okay, हम देख.
We may see the needle also inside.
Yeah. Now, syringing. Don't go
Yes.
too. Yeah. Beautiful. Thank you. Thanks. It's a nicely patent and all that.
Yes.
Now I'll go back to my 0-degree telescope.
So what are your indications for putting a stent?
This was the question.
Yeah, we have tried all that. Stents have their problems, but now the indications are only limited to if we mess up this surgery, number one. Sometimes we do. Number two is revision cases. And if the sac is very, very narrow and fibrosed. But otherwise, really, real indications don't exist so much. Even revision cases we have done without stenting.
Yes.
I
So
think
it's
those stents are more useful if there is a canalicular block which you have dilated. Yeah.
true.
Yes.
So
And
now
sir,
we have got all that.
sometimes in
Yeah,
some of
please.
our patients, we see that only
Yeah.
one canalicula is completely blocked.
Yeah.
Then in such cases, how you or ophthalmologist colleagues, they manage?
See, if only one is blocked, then we still go through the same DCR because there should be also an NLD block also.
Yes.
If there's no NLD block, there's no point because the NLD block has to be there. Because doing only a what we call a pre-sacal, the pre-sac, that is the upper lacrimal system, if it is blocked and the NLD is not blocked, there's no point. If one is patent, you can do not a big deal.
No, if it's a pure canalicular block, it's more in the area of the ophthalmologist rather than the ENT.
Yes, sir.
Yes, sir.
Oh, मुझे दूसरी से देना मेरे चीफ इसको मैं थोड़ा काटता हूँ. Now I'm just splitting it. Now we'll have a flap which is going up and down, superior and inferior flap. A ballpoint. This is just to cover up the bone a bit. Still not fully released, so I will release it still further. And we can also do, because the flap is quite large,
Yeah, trimming we can do.
we can still trim a bit. So let's see, this should go a bit. Okay, now this goes, but this is tethered to the,
Oh, that's nice.
yeah. But now this is a bit too big, right? It will not drape appropriately. So, scissors.
So suppose while elevating this mucosal flap, Devinder sir,
Sorry?
suppose while elevating this mucosal flap, the mucosal flap comes out
Huh.
as such. So can we keep the free mucosal flap here?
Yes, yes. I think that's definitely on because in so many of these draft 3 procedures, we keep a free flap. And now this is better, right?
Yeah, lovely.
So this comes out here and this can Anji? Oh, you're right, thanks. Dr. Jatin is here with me and he's reminding me that we always do the scarification of the junction of the nasolacrimal duct and the
Yes, what we say the sump sign or
thumb.
something like
Yeah,
that.
so we do that also. Okay. Now, sickle knife.
There is a question, role of antibiotic irrigation for syringing after DCR.
Actually, just the nasal, I mean, the drops are enough. Syringing, no.
And if
I mean,
suppose if you put a stent, then how long is the stent you leave? Means for how long you keep the stent? If you are stenting, what
Yeah.
you said in some of the cases, then for how long you keep the stent?
Minimum of 3 weeks. Now, this is the scarification here. And then when we cover this up, this will be pretty good. So, there a ballpoint. I'm putting the posterior flap still backward, but I do find that this is a bit okay.
Thicker and bulky also.
That's definitely there. But this is coming out okay. I think we can just compress it and leave it because here we have a wide opening.
Yeah,
And
nice
this is
big
going
opening.
backward right into the Aganesa area. I won't really call it a cell, it's basic more of an area right now. And this is the thoda ye jo hai here. I would like it to be a bit up. And this slightly redundant mucosa, I mean, not much of fibrosis will take place because we have slightly redundant mucosa. It's okay.
Yeah, you don't have exposed bone anywhere now.
We don't have exposed, and this is the anterior.
It's also
one.
draping nicely.
It
right?
is also draping nicely. So I'm just going to put a bit of gel foam and then come out.
Absolutely fabulous demonstration, Lavender.
Thank you so much, sir.
Yeah, every step planned and executed with perfection. And I think compliments also to your anesthetists for giving you the kind of feel that they have given.
Yes.
Thank you. Thank you very much. I think we'll shift now focus because the other person is waiting. Are you okay through with it? You're just going to put a gel foam there now, right?
I'm just going to pull gel foam in these small areas, anterior.
So is it
and
okay for us
posterior.
to shift now? Is it okay by you?
Sir, if you give me 2 minutes, I'll be
Okay, fine.
more happy. There, gel foam.
One last question, Dr. Devinder. How frequently the ophthalmologist is available to you? Do you have the luxury of a ophthalmologist always available while doing the surgery?
See, when we operate, the OT is all there, and there's no hassle because everyone is very cooperative in this place.
In our own practice, the ophthalmologist refers to us with this NLD, and most of the times we are alone only doing it.
No, I think that, I mean, we have a very good faculty here.
Dr. Devinder Rai is so charming, nobody says no to him. Remember that.
You're right, sir.
Thank you, sir, and thank you for the compliment. Sir, यही बस दिखाना था मुझे that I'm already doing that, and we just put something
I
here.
think, no, what is wonderful is that every step you told us what you have in mind, what you're going to do, and it was executed exactly as planned. That's beautiful.
Thank you, sir.
Thank you, Devinder. Once again, big applause for him.
Thank you, sir.
Okay. The other person is now ready, so we'll shift there, okay?
Done, sir.
Thank you, sir.
Thanks.
For felicitation, now I request Mr. Rajneesh to please come forward. Okay. Okay. Mr. Dinesh, you can inform Dr. Jyotsna's team to be ready and we can go on live.
Ballpoint.
I request Dr. Narendra Verma to please come ahead and request Mr. Rajneesh and Kirtane sir to please felicitate Dr. Narendra Verma. Now I request Dr. Deepak Dalmia to please come ahead. I request Dr. Bhandari to please come ahead. Thank you, sir. Thank you so much. With this, we move on to the next surgery by Dr. Jyotsna Jagtap, rhinoplasty. For the surgery, we have moderators, Dr. Lata Devi. I request ma'am to please come ahead. I request Mr. Rajneesh to please welcome Dr. Lata Devi. Then we have Dr. Ritu Seth. Then we have Dr. Shafqat Islam. I request sir to please come ahead for moderating the surgery. Thank you, sir. Thank you so much.
Good morning,
now I request
all.
Kirtane sir to please take over this.
Yeah. Hello.
Hello?
Hello. Ma'am, can you hear me? OT.
Good morning, Jyotsna. This is Dr. Ritu here. Can you hear us?
Hello.
Hello, Jyotsna. This is Dr. Ritu here. Can you hear us?
Yeah, Ritu, I can hear you.
Yeah.
I hope my audio and can you, what can you see on picture? You
Yeah,
can see the patient?
Yes, we can see clearly and the house is packed
Okay,
to see
great.
your surgery.
Thank you so much. Good morning, all. It's really an honor and privilege for me to get this opportunity. For that, I am grateful to Kirtane sir and team MacLeods for giving this opportunity. So today the patient for rhinoplasty, I have already assessment. We will start the video for assessment and then I will go with the steps of surgery. Can we have the video for assessment? We can start. Yeah, first video. So this is the patient for rhinoplasty today. This is a 24-year-old male patient who came to us mainly for aesthetic correction. He had little bit of blocking of nose, especially on the right side. but his main complaint was his C-shaped deviation and bulbosity of the tip. So while assessing the patient for rhinoplasty, the photos are taken in different views. This is the frontal view, where the face is divided into 3 horizontal parts by marking lines from the hairline to glabella, glabella to subnasally, and subnasally to mental. Similarly, the face is divided into 1/5 by making these vertical lines. When we assess this patient, the face looks more wider on the right side than the left side. So on assessing the nose of this patient, there is C-shaped deformity. The dorsal aesthetic lines are parallel, but these are curved. And there is bulbosity of the tip of the nose. The bulbosity is mainly in the supratip area, where it can be because of the convexity of the lateral crus. There can be little bit of malposition of the lateral crus also. The alar base seems okay, but the bony width on the right side is little bit longer than the left side, mainly because of the deviated nose. This way, I have marked the C shape, which can be prominently seen. The lateral view, we can see there is nasal hump over the dorsum. The nasolabial angle looks to be around 90 degrees. The tip seems to be over projected, giving the appearance of tension nose. Similarly, on the right lateral view, this is the left oblique view, which is again showing prominence of nasal hump and over projected tip. Similarly, in the oblique view, hump is seen in a better way. In basal view, the shape and size of the nostril are seen, as well as the triangular shape of the base of the nose can be marked. Usually it is equilateral triangle. The shape of the nostril is teardrop shape, that is normal. In this patient, the nostril shape is wider, more on the right side than the left side. The helicopter view, again we can see the C-shaped deviation, which is prominently seen. So the operative plan for this case, the stepwise approach what I am planning is first infiltration, then open approach rhinoplasty. So incision would be transcolumnar with bilateral infracartilaginous incision. The skin flaps will be elevated, septum would be exposed. Removal of bony or cartilaginous hump will be done. Then I will be reassessing the plan regarding the septal harvest. Osteotomies will be done. Graft preparations, spreader grafts would be fixed. Tip plasty, where lateral crural modification would be done. Septal extension graft and fixation. Then the dermal sutures and tip only graft if required. Then the incision lines would be closed. The FDC will be put on the dorsum, POP and Doyle splint. So let us go ahead with the surgical step.
Dr. Jyotsna?
Yes, Ritu.
So this is the patient. Dr. Jyotsna?
Yeah.
Yeah.
Stop that video.
Have you taken the consent form? Is it the WHO consent form you use or any consent form which has
Just
been?
a minute, there is some audio disturbances. Can you stop that? So while assessing the patient for rhinoplasty, the photos are taken in different views. This is the frontal view, where the face is divided into 3 horizontal parts by taking
I think we need to stop the video. It's running in the background.
Yeah. We just told it.
The audio of the video.
Audio also, yeah.
Do you use the WHO consent form? Which type of
Yeah.
consent form you use for?
Yeah, there is one consent form which is devised by AOI. So we are using, and also it is approved in our ARSI committee, that is Association of Rhinoplasty Surgeons of India. So that form we are using, where the consent is very elaborate.
Yeah.
And so along with, so everything is explained to the patients. You need to give a special counseling sessions to the patients, especially for these cosmetic surgeries, aesthetic surgeries. So lot of time is spent with the patients regarding, first of all, what are the deformities, those are grasped by the patients, what he is aware of. So that can be functional problems as well as aesthetic problems.
Yeah.
So we need to discuss with the patients exactly what he is aware of his problems. And then once we know and what he wants the changes to be done.
Okay.
So accordingly we can discuss, and then if the patient has extra expectations, then definitely we can discuss what we are expecting, what are the extra deformities that we can look other than the patient is aware of. So sometimes there can be facial asymmetry and patient is not aware of that. So that is very important to discuss with the patient preoperatively, because then in those cases, maybe very straight nose will not look good on that face.
Yeah.
So all these type of facial asymmetries, other deformities, those are to be discussed with the patients. And then along with that, in case patients has too much of expectations, then we have to clearly tell the patient that what we cannot do. Even that is important, so that even patient can decide whether he wants to get operated or not. And then there won't be much of post-operative stress to the operating surgeon also. So
Madam,
that
nowadays,
communication and the wavelength should be matching between the surgeon and the patient.
some patients ask for the view of the corrected rhinoplasty face. Are you having any software, and the patients do they demand
Yes,
the
yes.
post-op
Many
view?
patients, yes, ma'am. Very many patients demand for that. So I do have a software where the plastic surgery simulator software. So I can share it later on. The thing is, I do
Difficult, actually.
yeah, I do make the changes. I do pre-op, post-op simulation.
Okay.
But I usually tell the patient to come and see that simulation in my clinic. And
Okay.
also tell the patient that there are limitations to the surgery and the simulation also, because
Precisely.
sometimes some simulations we cannot do, some corrections we cannot do just in the simulation, but we can
Yes,
do
ma'am.
better way on the patient. So, and then I definitely don't give those pictures to the patient, because otherwise post-operatively they can give trouble. So I tell them to come and see it on my console. So
Hello,
I'm
Dr.
starting.
Jyotsna. Hello, Dr. Jyotsna.
Yeah, good morning.
I'm Dr. Shafkat. It's great to see you operating.
Yeah, nice to hear from you.
Just for the sake of the audience, what is the infiltration you used in this patient?
Yeah, I have used ropivacaine, and sorry, we have a video of infiltration, so I will tell the audiovisual people to show that video also.
Okay, Josna, interrupting you for just one announcement to all the people who are staying at the Taj. The checkout time is 12. So if you haven't checked out by now, please go and complete that formality. Otherwise, an extra day's charge will have to be paid. So those of you who are staying at the Taj and not checked out, please do that immediately because the checkout time is 12 o'clock. Yeah, Josna, back to you.
Oh, yes, sir. Thank you. So there is, usually I wait for 10 to 15 minutes. So because of lack of time, I have already infiltrated the patient and then I have recorded the same. So we are just showing you the video of infiltration.
Okay.
Till then, you can explain the incision to us, Jyotsna. Infiltration we can see later on, because I think.
Right, sir? Tell me. Recording चालू करना है? Okay.
Josna,
So the patient is under general anesthesia.
I think you can start
Most of
with the
patients I
surgery.
prefer to do under general anesthesia.
Hello, can you hear me?
Whenever the
Josna?
osteotomies are needed or the patient is,
Josna, can you hear me?
they can't hear me. Then sang audio वाल्यांना सांग.
Hello, no, can you hear me? We can hear you. Are you able to hear
Okay,
me?
sir. Yes, sir. Yes, sir.
I think you proceed with the surgery now. Don't.
Okay, sir.
Okay, fine. Explain the incision, please.
Yes. So it is a transcolumnar with bilateral infracartilaginous incision. So I have marked the transcolumnar incision where the base is at the narrowest part of the columella and inverted V shape and the infracartilaginous. So I'll be starting with infracartilaginous incision. It has 3 parts. So I'll be putting my alar retractor, putting the thumb inside so as to make the lateral crura prominent. And then you can see the lateral crura. I am going along the lateral crura. So this is the lateral part, then the middle part, and the medial part. So for our beginner friends, this is the soft triangle, which is devoid of cartilaginous tissue. So you have to take care that you are not coming very near to the edge, and then the medial part of the incision. Similarly, on the opposite side, the lateral part, middle part, and the medial part. So this is the retrograde dissection. So I am going just above the lateral crus. You can see the rim of the lateral crus in this retrograde fashion. On both sides.
So are you wearing magnifying loops?
Yes. So that is very much important, magnifying loops, and so as to give precision in dissection as well as suturing as well as incisions. I am using magnifying loop with 2.5 x magnification.
So the camera is attached to the loop or it's external camera?
No, external camera. Actually, I tried with the camera which is attached to the loop also, but then it moves with my head. So the picture is, or the video is not very stable in that type. So I don't prefer that one. So
Madam,
in this,
concentration
you have
of
to take
the
care.
infiltration anesthesia.
Yeah.
What did you use? You said ropivacaine. And how much is the concentration?
Yeah, in the ropivacaine, 0.2% ropivacaine, in which I add 0.2 ml. So it comes to 1 in 1 lakh. In 20 cc, I add 0.2 ml.
Okay.
So the previous incision I took with 15 number blade. This is with the 11 number blade. I'm just keeping this buds inside so that the medial crura are not damaged. Best. Brush, please. The retractor.
Josna, keep a commentary going as you're doing it.
Yes, yes. So this is the elevation of the skin flap. Now, and I am going into the SMAS layer or supraperichondrial dissection I have done with these curved scissors. And now I have exposed the lateral crus, the low lateral cartilage, which has three parts: the lateral crus, the dome, and the medial crus, and then it ends into the foot plate area. Then once we dissect it further, we'll get this dermodomal ligament or ligament of Pitangwes. So you can see this ligament. I'll be cutting this ligament so as to do the dorsal dissection. From here, I'll be going.
Try to keep the picture.
Centralized, please.
Dorsal.
Centralized.
They've got two cams. This is the VTOM picture. Actually, it's a direct picture from the camera. Yeah, I think that's a nice centralization. So you'll have to excuse it. If it goes off center, we'll keep on reminding you. Okay.
Yes, please, please. Yeah.
Camera.
Flush, please.
Dr. Jyotsna, have you ever thought about raising subpericordial flaps in the lower lateral cartilages?
No, actually, I don't prefer, especially in our Indian noses, because our cartilages are very thin. And even in this patient, you can see, usually in India, we have thick skin and thinner cartilages. And if we do the dissection subperichondrially, there are chances of losing the blood supply and weakening the cartilages. So I usually prefer to do supraperichondrial dissection. So since the patient is having hump over the dorsum and skin is usually thinner on the rhinion at the keystone area, so you have to be really very careful while elevating the skin flap. You have to just go above the perichondrium and maintain that plane and go up to the periosteum over the nasal bones. So this is the tunnel which I have made. Flush, please.
How far laterally do you, Dr. Jyotsna? How far laterally do you usually elevate the flap on the dorsum, bony dorsum?
Dorsum, I don't elevate too much. It is just so as to I can reach up to the root of the nose, because at the end of the surgery, in case I need a pocket for augmentation or for putting dice cartilage, it should stay in that pocket. And I don't, I'm not using piezo as such, so I don't need a very wide pocket. So this is a self-retaining retractor, like a lead retractor, which is helpful. This one. Skin hook, please.
You say this is a self-retaining. So what's the other end like? Where does it fit into?
So that has a silicone cable-like structure, which are we fixing it to the towel. Loosely. So I'll be going now and This is the crura, both the crura, and this one is the intercrural ligament. So I have to go and dissect the anterior septal angle. Here is- oh, this is
Can you
one was-
focus, madam?
Yes.
Little bit. Yes, yes, yes.
Better?
Just went out of focus. Little bit more.
Which camera you were showing?
Yeah, this is
Focus
fine. This is
पाहिजे
fine.
तुम्हाला.
This is fine. Don't change. Yeah.
Yeah. Okay. Flush, please.
Madam, what is your opinion on endoscopic rhinoplasty? Now it has come up.
Yeah, it is a good approach, especially for maybe for limited cases. But since I am trained in this open approach rhinoplasty, I feel that I can give more precise surgery with better results. I usually prefer closed this open approach.
Okay, madam.
Definitely for a small hump noses or a single deformity where the patient, now this patient you can see there is deviation, there is hump, as
Yes.
well as tip is to be corrected. So I don't think so this type of multiple deformities patient we can, at least I am not expertise in
Endoscopic.
close approach.
What methods of reduction of the hump do you employ usually in your patients?
So hump reduction can be done en bloc or it can be done incremental. So usually what I prefer is to do incremental reduction because first of all, we don't see that much of the hump noses as are seen in north part of the India. And so incremental reduction is always safer.
And you use have a drill or what do you use, scissors?
Yes, yes. I do use piezo also. I use drill also.
So you're trying to separate the lateral cartilages from the
I am
septum,
exposing
elevating
the septum by, this is the anterior septal angle. So this is the lateral crus of lower lateral cartilage, both the sides. This one is the dorsum, cartilaginous dorsum, where the septum and the bilateral upper lateral cartilages are attached. So I have taken a small incision so as to elevate the mucoperichondrium on the dorsum. So as I have mentioned in my first assessment and the stepwise approach. So the first step was after anesthesia was infiltration, then incision. That was transcolumnar with infracartilaginous and then elevation of the skin flap. And now this step is septal exposure. So this caudal part of the septum, there is little bit of fibrous attachment. So normally in septoplasty, while we do by transfixation or hemitransfixion incision, the separation of the mucoperichondrium is little bit easier. Here we can get little bit fibrous attachments and may take some time so as to elevate the mucoperichondrium. So this way you can just take with the
You are elevating with
scissors.
scissors only,
Yeah.
madam. So what is that?
With sharp scissors, I went into the plane which I wanted. So once I'm sure I got the plane, now I'm using this mucoperichondrium elevator. This one is a sharp one, and then I use this suction elevator.
Have you ever thought about using the push down technique, which is nowadays a lot in vogue?
Again, I have not used much because we have multiple deformities and especially crooked noses. So when the patient is having small just humps, this can be much useful. So once we have elevated the mucoperichondrium,
How many times do you use this preoperative CT scan to assess the degree of the bony hump?
for the bony hump?
Yeah.
Usually I do the preoperative CT scan, especially in patients with deviated noses, patients having history of rhinitis, sinusitis, to check for sinusitis or blockage, or any other like concabulosa, or in cases where patient is having patients are come for revision rhinoplasty, or
Right.
syndromic patients like cleft palate, cleft lip, cleft rhinoplasty patients, or Binder's syndrome, or congenital deformity patients. So to tell you the steps in between.
Madam, do you combine FES with rhinoplasty?
Yeah, I'll come to this question. Just one step I would like to tell to our fellows. So this is the upper lateral cartilage and the septum. What I did was elevated the mucoperichondrium, and then I elevated the mucoperichondrium from below the upper lateral cartilage also. So that was the submucosal tunnel. And then I have cut this, separated the upper lateral cartilage from the septum up to the keystone area. So I'll demonstrate on the opposite side also. Yes, madam, sorry.
FES is also done along with rhinoplasty.
Face, when it is infective type of thing, I don't usually prefer. So I don't do face along with rhinoplasty, but it is just limited, like some concabulosa or something, then just especially which is causing obstruction, then I do it. Otherwise, I don't do it.
Okay.
Is there some special type of forceps you are using? The tip looks different.
Yeah. This is a cartilage holding forceps. So it is traumatic for the cartilages. You can see the serrations, fine serrations. So the grip is good and I don't have to give much pressure on the cartilage. So it doesn't damage the cartilage.
Company?
This is available in Indian companies also, and with Medicon also.
Okay.
With Medicon, their serrations are very fine as compared to the Indian ones.
There's a question from
So-
the audience. What are the indications that you found in your practice for extracorporeal septorhinoplasty, septoplasty?
Yeah, that is a good question. Extracorporeal septorhinoplasty, especially for the deviated noses. So whenever there is septal deformity, which I am not able to correct in situ, then I have to take the septum out. So usually what are these deformities? When the septum is deviated in more than one dimension. So anteroposterior and craniocaudal, both or multiple fracture lines if the patient is having, then severely deviated noses, then I do extracorporeal. Again in extracorporeal septoplasty, there are there are types of extracorporeal septoplasty. So either extracorporeal septoplasty or partial extracorporeal septoplasty. So this is the thing I was telling you. This is the submucosal tunnel. So I am elevating the mucoperichondrium from below the upper lateral cartilage. You will be able to see the movement of my instrument. And this is why this is important. If you don't elevate it, then inadvertently you can cut the mucosa or mucoperichondrium. 11 number plate, please. And you can enter into the nasal cavity. So that has to be avoided, because when you are putting the spreader grafts, those grafts will be exposed into the nasal cavity and can get infected. So you have to be really careful. So I am hitting the bone at the keystone area and cutting the upper lateral cartilage from the septum.
Have you ever tried using spreader flaps instead of these spreader grafts?
Yes. Spreader flap, definitely.
And what is your
In
experience with both?
In cases of hump noses, when the hump excised is 3 millimeter or more than the 3 millimeters, then the rest of the upper lateral cartilages are usually higher once you remove the hump. And if it is 3 millimeter more, then I do the spreader flaps. And the results are really good. I am happy with the results of the spreader flaps.
Have you ever tried giving relaxing incisions on the spreader flaps to reduce the contour or not?
On the?
Relaxing incisions on the spreader flaps to reduce the contour.
Yes. I do give partial cuts, and then only we are able to fold it inside. So I do give those incisions. So there is a spur on the right side. So as I mentioned in my steps, we have exposed the septum. Now we'll be going to the removal of the hump. So for the beginners, it is important that hump excision is to be done before septal harvest, because while harvesting the septum, we will be keeping 1 centimeter of the dorsal strut and 1 centimeter of the caudal strut. If we harvest the septum first and then remove the dorsal hump, then there are chances that this cartilage will reduce in the height, and we may not get this 1 centimeter of the dorsal strut. So, and because of that, then it may become weak, and later on again there would be deviation.
What if the cartilage is sometimes it's extremely severely twisted at the spine, and you don't get an idea about when you unfurl the cartilage and make it straight, how then you decide that what height you have to keep, especially in deviated noses, twisted ones?
Sorry, can you repeat the question again?
I mean, many a times you have a deviation which is very severe chordally, and when you unwind the cartilage, then how do you, because then it becomes longer, and when you get it back to the spine, how then you decide about the
Yes,
height?
then you have to keep the flap back again and see your nasofacial angle, the tip projection, and then you have to judge accordingly how much height of the caudal septum you need, and ideally where the caudal septum or the anterior septal angle should lie. And with that judgment, you will be able to keep the height.
Madam, you take the periosteum incision on the.
Yes, I took the incision on the periosteum. Yeah, over here.
You take a
This is the
horizontal
keystone
incision.
area. If you are able to see
Yeah,
clearly,
yeah,
this is
yeah.
yeah. So this is the keystone area, where what is the keystone area? It is the attachment of bony and the cartilaginous parts. So it is attachment of two nasal bones, the bony septum, perpendicular plate of ethmoid, then the cartilaginous septum, quadrangular cartilage, and the two upper lateral cartilages. So three cartilages and three bony parts. This is the union of six structures at the keystone area, and this is very important to maintain the keystone area. Otherwise, there are chances of having the saddle deformity at the keystone area if it is disturbed, or inverted V deformity. So this is the keystone area. I just took the incision above the keystone area over the mucoperiosteum, and then elevated this mucoperiosteum up to the root of the nose. So since this patient is having dorsal hump, bony hump, as well as a little bit of cartilaginous hump, so I will have to reduce both bony and the cartilaginous hump. Bony hump I will reduce with the coarse diamond burr.
How far back up do you go when you're using a drill for hump reduction?
Sorry?
I mean, how far back do you lift this flap, this subperiosteal flap?
So my flap is elevated up to the root of the nose.
Root of the nose.
So definitely beyond the hump.
And laterally?
You can
When
see.
you're drilling and laterally?
Laterally also, depending upon the extent of the hump, as well as a little bit beyond where I want to do a paramedian osteotomy in the normal cases. So it is at least 3 millimeter from the midline on both the sides. So if there is hump reduction, then we may not need paramedian osteotomies. It depends on how much hump reduction is needed. So this is a coarse diamond burr.
What is the speed of the burr that you usually employ when you are drilling at the bone in the dorsum?
I usually keep not very fast and not very slow. Speed kami kar.
Can we centralize the picture?
Yeah.
Because many a times this periosteum gets wound in this bar. So how do you prevent that?
Yeah, so we have got this sheath on the burr, which is fixed to the
Can't actually see.
handpiece.
Yeah.
Can you see?
Yeah.
Yeah, so only this much of the burr is exposed. So that reduces. And then you need a good exposure also, so as to reduce, like loose कर. काटते तितना आणि खाली पिन
And what is the width of the bar that you're using? 3 of. What is the width of the bar that you're using? Size?
This is 8 millimeter. So there are 2-3 bursts. So to start with, I use this little bit wider.
Is it any method to correct it, or can you diagnose the failure using complex solution?
There's a question from the audience that if there's a damage to the keystone area, how do you usually correct it during surgery?
Yeah, so that is very important. If there is damage to keystone area, you have to correct it immediately.
And what do you use in that correction? The audience wants to know.
Yeah, so either if there is damage and dislocation of the cartilages
And is coming in the way.
septum. Sorry. So, yeah, if there is dislocation of the cartilage and septum, so there is damage to the keystone area, then the cartilage and bones get separated. In that situation, you have to fix it with the sutures. So, fixing it with the sutures, you have to drill with the there are 2 types of sutures which are described. Professor Gubish has devised or he has demonstrated crisscross sutures, or Professor Hack, Sebastian Hack has, when especially the nasal bones are low, what you can do is
TTC sutures.
with the Hack, transcutaneous fixation can be done. Transosseous transcutaneous fixation. Suction, please. So, while
Josna, when you're drilling, your hand
Yeah.
comes in the way. So there is another camera on the side if that can be used to, if that picture can be shown.
Yes.
Because when you're drilling, your hand completely
Okay,
blocks
okay.
our total view.
Yeah, I will tell the audiovisual people to take care of it. मेरा हाथ बीच में आ रहा है. Okay. थम. Okay. So every time I feel that little bit of drilling is done, I go again back and externally I check how much reduction is done, and in case if needed, then I do a little bit more.
The incremental reduction.
Yeah, incremental reduction.
You use more of the drilling than piezo.
Yeah, piezo, I feel it is a little bit slower.
Yeah.
So drilling is faster. Yeah. So I feel bony reduction is sufficient. Now I will reduce the cartilage genus part. ये सोड जरा मैं एक्सपोज करा लगेल जरा सहज ऐसे से
Near the spine, are you exposing? You want to expose near the spine?
yeah, exposure of the spine. But more than that, I am just getting little bit of hindrance because of this flap when I am working on the and retracting the skin flap. It was just for releasing of the flap. Flush, please. Go on. So after reduction of the bony parts, I'll be reducing the cartilage. 11 number blade. Skin hook, please. Again, this would be incremental reduction.
Ma'am,
Yeah.
hello, ma'am. This is Sandeep Sathe.
Hi, Sandeep.
Ma'am, what is your take on use of RASP at this stage? Hello?
Yeah. Use of
Using
RASP.
of RASP, yeah.
Yes, yes. I do use RASP also. So it depends upon what you are comfortable with. So if it is isolated hump on one side, I use RASP more in those cases.
Okay.
Cartilage.
Maybe side camera can give us a nice idea about the reduction.
Yes. Side camera, can you come from that side? इतना समोर में. Oh, can you see the side view now?
Yes, ma'am.
yeah.
Yes. There's
Yeah.
slight
So the
Mori hump
hump-
still there.
Little
Yeah.
bit hump is there.
Yeah.
This one?
Yeah.
Maybe I'll rasp it.
Yeah. That is a better idea, I guess. Rather than using drill.
No, finer adjustments can be done
Yeah.
with the rasp. Yeah. And since the patient's skin is very thin, a little bit minor, I think it is more of more than cartilage, more than bone. It is the cartilaginous, like upper lateral cartilage, the ends of the upper lateral cartilages which are protruding. Number blade. Since we have cut only the septum, it is the upper lateral cartilage which is giving the appearance of the hump. Okay. Flush and suction. Inch kilo, 11 number blade. Okay.
Upper lateral cartilage you are resecting, madam?
Yes, yes. Since we reduce the cartilaginous hump, like the cartilage, the septum, but the cartilage was still at the higher level. So that was giving the appearance of the hump. And the rasp. Fine rasp. Look up. Yeah, you have to hold the head and rasp it.
Any particular direction you employ, or you just go it vertically up and down?
Yeah, it is up and down.
Maybe you can show after reduction how this bone dust coming into a rasp and how
Yeah.
rasp is actually
Can you see
designed.
this?
Yeah, yeah. This.
So it is both ways. The cutting is there on both ways. And after rasping and after bony reduction, always remember to flush the area very well, because those bony spicules can give sense
Pseudo-deformity.
irregularities or granuloma formation.
Now it looks better.
Yeah. So our next step is septal harvest. You can
In
show
all
that
cases,
list.
do you do osteotomy in all cases of hump reduction, osseous hump reduction? In all cases?
Yeah, if there is open roof deformity after after hump reduction, then I have to do the osteotomy so as to reduce that open hump deformity, open roof deformity.
Yeah.
So now this is the step 6 of the septal harvest. We have the steps which we have written. So I'll mark the septum, keeping 1 centimeter caudal and dorsal intact. And
Yeah, we are getting the steps. I think it's a better idea to put this steps in OT, because there
yeah,
are almost 20-25 steps we are supposed to perform.
and then when you assess, and then if you write down the steps, you are very clear about what you want to do, and it makes the surgery easier. I have marked the incision site on the septum, and it is a C-shaped incision and not a
Perpendicular.
yeah, in right angle direction.
So mostly we use vernier caliper for
Yes,
measurement of
use
this.
vernier caliper, and then
Yeah, we got it.
mark the
We got these
incision.
steps.
हे दाखव आतमध्ये.
Operative.
Could you see when I was taking the incision and marking it?
Yes, yes.
Yeah. 15 number blade.
Is it like L-shaped marking?
15 number, sorry, 11 number blade, please. Yeah, it is more of C shape, not the L shape, because L will give right angle over here. This would be right angled, and then that makes the junction weak, and then there are chances of fracturing the septum.
Okay.
So I'll be separating it from the vomer. There is a bony spur also. Eleven number blade. Sharp shears. Omen scissor. So the extracorporeal septoplasty, what we were talking about, is mainly done when there is multiple fracture lines to it, and when it cannot be here's the
Are you planning to have a perpendicular plate of ethmoid also?
there is a spur, so I'll be excising the bone. So let us see, in case if needed, we can use it. So sometimes what happens, there is after even excising this cartilage or harvesting this graft, the septum sometimes remains curved. In those cases, I usually dislocate it from the anterior nasal spine also. Now it is quite straight and it is fixed to the anterior nasal spine very well. So if there is some curvature, then usually I separate the attachments and then make it straight and then refix it again to the anterior nasal spine.
How do you fix it, madam? By doing drill holes directly on the intranasal spine or
Yes,
the
yes.
periosteum?
Holes. Yes, yes. Holes, no, not on the periosteum. I do it on the anterior nasal spine, make drill holes on the anterior nasal spine and fix it.
Okay.
So this is the septum which is harvested.
Hi, Joshna. I'm Dr. Supriya here.
Hello.
Hi. So
Hi.
how you think about structural septoplasty, rhinoplasty, structural?
So this is the structural.
No, about just removing the septum below the hump. So what do you think about that? So that.
So when you are preserving the structure, L-shaped structure, this is
No,
a
not,
structural rhinoplasty.
what
The other one is a preservation rhinoplasty.
Yeah, no, what we have been trying at, to say that when we remove the septum from below the, wherever there's a hump, we have to remove the septum from that area. Means above, what you have removed now, just above that, if you remove it, then the upper lateral, whatever dome is there, it drops down. About that I'm asking. Do you have any idea?
Bony scissor, please. Bony scissor, please. So, are you talking about preservation rhinoplasty?
Yeah, preservation, yes. I'm talking about that. But when we excise the septum just below the dome, wherever there is a hump, so it helps in dropping the roof also. So there's no need to remove the hump exactly from above.
Yeah. So
Got
that is
the
a
idea?
preservation. Yeah, that is a preservation or would let down or push down technique you're
Yes,
talking
push
about.
down technique. Yeah, it
Yeah.
will work very nice in this case actually.
Yeah, but
I've just I mean, it's a nice demonstration. Just a word with you, nothing than that.
yeah, definitely. Even that is a good technique. But this is a technique which we have been doing since a long time and more well versed with it.
Yeah, and one more
It
thing.
is the preferences of maybe.
Yeah. One more thing, there is no open roof when we do this type of removal of septum. So there is, if we don't put a spreader graft, also works well. Just
Yeah, but he has a
add
little
on
bit
it.
of hourglass type of
Yes.
appearance.
No, true.
So for opening off of the internal nasal valve and giving a straighter dorsal aesthetic line, I will have to put the spreader grafts. Before that, I am planning to go for osteotomies because he has this C-shaped deviation.
No, it was just an add-on, nothing else. Yeah, you're doing wonderful.
Yeah, thank you. So I'll be going ahead with the paramedian osteotomies.
How many times have you done intermediate osteotomies in case of twisted?
I don't prefer to do intermediate osteotomies. What I do is ostectomy. Don't mosquitoes. Because I feel there is too much of disturbance of the bony wall if we do intermediate osteotomy.
And how do you break the banana effect in case of the convexity on that side? You feel it?
I can rasp it, or I can reduce with the drill. And I do the ostectomy over here. I remove the triangular part of the bone, just lateral to the paramedian osteotomy, so as I can make it straighter after thinning it with the burrs. So I am going for the paramedian osteotomy.
Ma'am, there's a request. If you are planning for a osteotomy, can you please mark on skin? So
Yes, sure,
about the paramedian low to low and transfers.
Yes, sure.
So that we'll come to know.
So marker, please.
There is a question from the audience, and they want to know what grafts do you use for augmentation?
Yeah. I'll take that question later. First, I'm just doing the osteotomy. So I'll answer the first question first. So I will be marking the osteotomies. So paramedian osteotomies are almost 2 millimeter away from the midline. So like this, up to the medial canthus. Then the lateral osteotomies, I'll be doing low to low osteotomy in the nasofacial groove, starting from the piriform aperture to the medial canthus, and then the transverse osteotomy. This is the transverse osteotomy at the medial canthus, and then in the nasofacial groove, low to low lateral osteotomy. So other types would be high to low lateral osteotomy, where the Webster's triangle, in case if you want to save, just because the anterior end of the inferior turbinate is attached to it. So that is one of the alternative to the low to low lateral osteotomy. Then you can do median oblique osteotomy like this, where the lateral osteotomy also goes obliquely and meets over here. So this is the other way of doing the osteotomies. But what I am planning to do is to get a proper paramedian, low to low, and then the transverse osteotomy. Yes.
And how do you negotiate the trauma that you can one can have at the medial canthus to the lacrimal apparatus?
For that, what I do usually, so flush please, flush, is after making an incision, I will be elevating the mucoperiosteum so as to push all the vessels and the.
Which millimeter osteotome, madam?
This is a 5 mm osteotome. So sometimes I do with the osteotome, sometimes I do with the Lindman's burr also. Go please. Go. Just a minute. Go.
Maybe external camera show us how this is happening. External camera. Zoom out, please.
Zoom out.
Yeah, better. Yeah. Now you can do.
For the lateral osteotomies, do you give an infiltration before you start your osteotomies, or?
So I have already given the infiltration, so I don't give it again at the start of the surgery. Yes. Then I'll go for the lateral osteotomies, where I'll be taking the tab incisions in the midpoint of the marking, which I have already done, hitting the bone on both sides in the nasofacial groove. After
What precautions do you take when you are trying to prevent this step deformity?
Yeah, so that the angle of the osteotome should be proper, and you have to be exactly in the nasofacial groove so as to reduce the step deformity. So I can hear the grating sound now. So I have elevated the mucoperiosteum over the bone. And the same thing retracts the vessels and the lacrimal apparatus also. This line is a little bit away from the lacrimal apparatus, so we are not coming near, but the angular vessels are definitely pushed apart when we are elevating the mucoperiosteum.
I guess you're using Gubish's 3 mm osteotome.
Yeah, this is 3 mm osteotome. Yeah, go.
And how do you place it? You keep it at what is the angulation that you use when you're
It is
doing
almost 90 degrees. Go. Go. Bas. Go. Go. So at this point of time, I ask for ice cold saline compresses so that the bleeding is less and the post-op edema ecchymosis is reduced. And continuously give the
You start at the nasal aperture, root of the nasal, or you start midway between the middle cancers?
No, I started at the piriform aperture. Yes. Go.
Yeah.
So I can feel the movement of the nasal bone. That is
How there's a question that how do you how often do you change this osteotome? I guess it's very costly by Indian standards.
actually I have a stone with which we can sharpen the osteotome, and almost before every case we sharpen the osteotome. I'm lucky to have a good assistant and a good staff nurse which are there with me since many years, and then they take care of the instrument also. Dislocation. Just.
The real stone, madam. It's a customized.
The stone, actually, I got that from also Medicon.
But I don't think they provide it now. I was asking for the same.
Oh, is it?
Yeah, they every time they tell you to send the osteotome to Germany for sharpening.
Oh, then that can be a marketing. Okay, go. Good.
So you autoclave the stone also?
Yes, yes.
Oh.
Usually that is done before autoclaving. Sharpening is done before autoclaving, but we have that stone which is autoclaved. The same can be autoclaved. Go. Go.
So hello.
Yeah.
So basically, what we need for good osteotomy is sharp instruments and
Definitely.
maybe this Teflon hammer and expertise.
I think mine is a fiber mallet.
Acha.
Now they have come up with the Teflon one.
Yeah, this one is fiber Medicon one.
Mm. Lost.
Can you tell something about the step deformity and how to avoid it?
Yeah, step deformity, if we are not in the proper line, that is not in the proper site, the nasofacial groove is exactly where the maxillary bone and the frontal process of maxilla, we are actually lateral osteotomies we are doing on the frontal process of maxilla. So where the two bones, that nasofacial angle, we have to be precisely at that level. And if it is not there, if we go a little bit above it, then there are chances. Yeah. That the osteotomy line will be palpable from outside. Now and then that is called as a step deformity. So that will be very difficult to correct post-operatively. Again, you will have to take the patient and do the osteotomies.
So how do
again.
you ensure that
Intraoperatively, if you find it out, madam, how do you correct it?
Then again, you will have to go and do the osteotomies again at the lower level, at the proper site.
And how do you ensure that you don't injure the, how deep do you take the osteotomy while you're doing osteotomy and not injuring the mucosa internally?
Yeah, so the give way sensation is very important. Once you get the give way sensation, you should stop over there. So you can see the change at now only. The dorsum has become straight. The curvature is gone after the osteotomy. I hope you are able to appreciate that.
Yes.
Yeah, we can appreciate that. Nowadays, they recommend that when you do paramedian osteotomies and when you're taking them up to spirally, you have to take it slightly sideways to keep a ledge of bone so it's not to destabilize the radix too much. Have you ever tried it?
Sorry, I didn't get you.
I mean, the paramedian osteotomies, they recommend that when you go up, you go slightly laterally instead of going straight up, because then you can destabilize the ledge of nasal bone, which is important because if that gets destabilized, then you can have
Yeah, but then my paramedian osteotomies are always a little bit away from the midline. And as we go up, definitely we go little bit laterally. So we'll be going to the next step now. I'll keep this ice cold saline pack and I'll be harvesting the grafts. We'll check what are the grafts are available and what are the grafts which we need. So I will need 2 spreader grafts and a septal extension graft. And what I am planning to do is tip modification. So हे दे मला दुसरं प्लेट.
Ma'am, hello.
Yeah.
What are the dimensions of this spreader graph you are planning?
So the width would be around 1.5 to 2 millimeters.
Okay,
And
almost 3
the
centimeter
the height, yeah, around 2 to 3 centimeters.
in length.
And yeah, length. And the height would be 2.5, 2 to 2.5 millimeters.
Yes.
So we can see the septum is in the center. We'll put the spreader grafts. And then we have a little bit work to do on the lower lateral cartilages. Flush, please.
Madam, columella strut is required in this case?
Yes, either I'll be putting a septal extension graft because there is droopiness of the tip. So I need to rotate the tip upwards. So for that, I'm planning to put a septal extension graft and the columellar strut.
Okay.
Mosquitoes, please. Suction. So these spreader grafts will go usually up to the upper lateral cartilages.
Have you ever considered using unilateral spreader grafts?
Yes, unilateral spreader grafts when there is more of the thickness on the upper lateral cartilage is there, then I put unilateral spreader graft, or I can put double spreader graft on one side and single spreader graft on one other side. What's थोडंसं push कर. Well. या बाजून दे. Suction, please.
How far under the nasal bones do you take the superior end of this graft?
It depends from case to case. In case if I want a widening of the bony pyramid, then I do put like extended spreader graft, which goes, which is like extended cephalically or it is just up to the keystone area.
And what about the open roof that is created when you fix these cartilages cephalically?
Then दूसरा. The cartilages go a little bit below the bone. So there is no open roof deformity which is created.
The other way around is we can bevel the upper edge of the
Yeah, we
cartilage.
can bevel also.
With 50 PDS, madam?
Yeah, this is 50 PDS. Mattress suture.
Ma'am, hello.
Yeah,
Ma'am, what is the code number for this suture material? People want to know.
that is W9872. If you want to take a picture, I'll just show it in the camera.
That would be better.
Yeah, because this is undyed and yeah, show it.
Not
Barabar hai.
easily available.
9872. Yeah, correct. Because everything matters in this PDS suture, definitely, because undyed, one thing, then the length of the needle, the reverse cutting type of the needle, and then the curvature. Because you have to go through and through. I'm taking this 5-layer sandwich graft I'm fixing. So if it is a shorter needle, it will be difficult for me to take these sutures because needle may not come from the other end. So this number definitely matters.
Ma'am, have you ever used taper cut rather than reverse cutting?
I am happy with this and the number, and usually it comes with this. Do you use taper cut?
No, ma'am. Just asking. Even I'm habitual of using this only.
If we don't get this, can we use the Vicryl?
No, preferably PDS only because the absorption, it is delayed absorbable. So this assembly and everything will get
Time to get
integrated properly over the period of time. So advisable to use PDS only. And it is easily available. So why you want to compromise on that?
Usually you give 3 mattress sutures.
Yeah, 3 sutures have taken. I take usually one around it also, but in this case, I might have to cut a little bit of the dorsal septum. So I just want to be sure I won't be cutting my sutures. So that's why I've taken a mattress one only. I'll be cutting a little bit of extra part of the
spreader graft.
spreader graft. Otherwise, it would be called as extended spreader graft. I don't want it in this case. When you want to increase the length of the nose, you can use extended spreader graft, which extends caudally.
And you do beveling of these caudal ends to...
Josna?
Yeah.
Dr. Kirtane here. Dr.
sir.
Vikas is going to be showing us some surgery. So he wants to know approximately how much more time would you be taking? Give us a rough estimate.
Maybe around 40 minutes.
40
30 to
minutes.
40,
40,
yeah.
45, can I say?
45, yeah. Because this will take the
No,
LR modification will take some time.
yeah. Sir, shall I tell him 45 minutes?
45 minutes, yeah.
We'll make it 50. Okay.
Yeah. Thank you, sir. So now we'll go for the tip.
I mean, the caudal ends of the spreader grafts, they do show when you keep them unbeveled. So you are planning beveling them?
I keep it up to the anterior end of the septum, like the up to the septal angle, then they show. At this level, usually they don't show. Actually, yes, this is showing a little bit. We can bevel it. Thank you for pointing that.
Something else on here.
Right. Mhm.
Yeah, now that we're fine.
So the cartilages are, the lateral crus is quite huge. Marker, caliper. You can see the size of this lateral crus is almost 12 millimeters. We can easily keep it between 6 to 8 millimeters. But since the cartilage is over here, so this one is almost up to 13 millimeters. Can you see my caliper?
Yes, yes.
Yeah. So I'll be keeping it at least 6 to 8 millimeters. And that is giving it convexity. Marking, please. Yeah. So infiltration, please. Again,
How
this
many times do
opposite
you
side,
employ the Kawasaki suture technique? And would you try one in this?
sorry, which technique?
The cranial suture technique of Kawasaki technique? Suture. Dome creation sutures.
Dome creation. Yeah, yeah. All the cases of open approach.
And previously you would do the same thing, or you've changed now to this? Because I see now your tips are much more sharper than.
So yeah, the previously we used to take the sutures which were
Transdermal.
Yeah, transdermal, and now we take a little bit of that gives a more of the modification. That gives more of straighter lateral crus. So that is the advantage of this modified technique.
Can we use the side camera, please?
Side camera, please.
Yeah, better.
Audio vision.
Yeah, we are
better,
getting.
better. We got the lateral beam.
You got, no? Okay. नाही मिळालं त्यांना.
So you are planning to remove, cutting and remove it or infolding
trimming,
it?
No, I am planning to infold
Yeah.
it. The reason is the cartilage is very thin.
So it's a lateral crural underlay technique that you're
Yeah,
applying.
infolding technique.
Infolding. I must say, this operative field is really, bloodless. Thanks to anesthetist.
Thanks to anesthetist,
Manisha
definitely.
ma'am.
Yeah, today we have Dr. Prachi with
Acha.
us.
Oh.
Ready, Mana? Black scissor. So I will dissect the layer inside.
Madam, you preferred cartilage infolding because they are weak?
Yes, yes.
Are you
And
exercising?
also convex also. So it will straighten the cartilage. Side knife है नहीं तो sharp elevator. Yeah, so it will make the convexity less prominent. So it will make it the cartilage straighter. And since these are large also, it will reduce the size. Similarly, on the opposite side, scissor them, converse scissor, please. Brush. Hey there, mother. Skin hook them.
So I think this cold saline flushes are also helping the field to be bloodless.
Yes, yes, that also helps. Clean also and it. Side knife.
Almost we are seeing millimeter to millimeter dissection, madam. Awesome dissection.
Thank you
And
so
it is
much.
bloodless.
Our anesthetist can comment a little bit. Madam, you want to say anything about your anesthesia? Hypotensive anesthesia? Anything specific you have used for this? The delegates are appreciating a lot. So you want to tell your secret about it? Forceps? Audio आहे का तुझ्याकडे? So
Hello.
Hello.
Hi, this is Dr. Prachi Sawant, anesthetist for today's
A
surgery.
little bit loud we want to hear, madam.
Hello, can you hear?
In a low voice. we are
Prachi, I think you'll need to hold the microphone closer to your mouth. You're very soft. जरा मोठ्याने बोल थोडी.
Can you hear, sir?
Yeah, yeah.
Yeah, loud.
Yes, loud and clear.
Loud and clear.
Okay, so actually, to maintain an hypotensive anesthesia, it is not a secret. Actually, madam gives a good infiltration, so that reduces my anesthetic requirements to a very large extent. So my half of my work gets done there only. And then just to maintain the hemodynamics, nothing like a different drug. Just give a good analgesia and maintain the depth of anesthesia. So that works well. And the major credit I think goes to Josna madam only. She gives a very good filtration. So like I really don't have to do much work with her when I'm working with her.
Thank you, Prachi. That is too modest.
So that is the truth.
So there is a little bit change in my planning. Actually, after reassessing, what I feel is definitely there is convexity, there is droopiness of tip, and there is over projection also. Are you able to hear me also?
Yes.
Yeah. So the thing is over here, after doing infolding, I have not sutured, but if I rotate the tip upwards and reduce that droopiness, then there is little bit bulge again. So what I have to do is I have to reduce the lateral crus also. For that, I will have to do lateral crural overlay. But that I won't be able to do keeping this cartilage intact, infolded cartilage. So there is little bit change in my plan. What I will do is I will excise this, I will do the cephalic trimming, and then I will do the lateral crural overlay. So that itself will also make the cartilage stiffer because we'll be overlapping. And that will help me reducing the projection of the tip. So, Dr. Sandeep, Dr. Ashfakat, what do you say about it?
We are agree with you, ma'am.
Yeah, I would have thought that had you given these these cranial tip suture technique, that could have given you an idea about how back the tip would go, and then you could have. I think if you.
But even the length of the crura is not going to reduce with these sutures. It will just make those
Because when you incorporate a part of the lateral crus on the middle part, that will lengthen the middle crura, and the lateral crura would automatically reduce in length.
still I feel that may not give complete justice to this bulging and convexity. So let us do the overlay. Hold this side. So lateral crural overlay is a technique where from the dome, usually what I do is caliper, please. Measure at least 8 millimeter from the dome marker. On both sides. Then infiltration de थोड़ा सा Are you able to see the markings and the crura
Yes,
properly?
yes, ma'am. Now better.
Yeah. So, what I'll be doing is first I will do the underlay first. धरून फिरू नकोस तू. So, vestibular skin I have separated from the lateral crus. On both sides, I will do the same. Then, काय झालं? पकडून ठेव जरा. Similarly, on the opposite side. Just you have to take care that you are not making a buttonholing in the vestibular skin as well as you are not damaging the cartilage at the same time.
How much of an overlap are you planning?
Yeah, after releasing, after cutting, after making a cut, I will overlap and see. Maybe up to 3 to 4 millimeter, I will overlap. needle. The important thing is you have to have symmetry also in this. Forceps, one more. 50 PDS. Mother central letter also. Hmm. Hmm. Yeah. Now I feel this would be better. Almost 3 millimeter of the overlap.
I would suggest
And
that you will have to release a part of the membranous at the columella, the membranous part of the septum. Then only your tip will go back. You
This
have
one,
to,
na?
right.
Yeah. Let us see. Forceps. Babu season. That is reducing tension on this. PDS. And I will have to take at least 3 sutures.
So these are 26 number needles you're using for transfixation? Okay.
Yes, yes. I think there is 126 and 127 number. I'm keeping the knot also inside. So that there is no not palpable post-operatively.
They are not related. Why are there hair cells in the nose? I don't know what it is. Man, why are there hair cells in the nose? They're flushed out with saline. It's talking about these hairs from the lower lateral cartilages. Some people in the audience,
Yeah.
they want to know there are some hair follicles probably on the lower lateral cartilages, which they are, I think,
Sorry?
pointing out. The hair follicles which, ma'am, you have trimmed, I think they are on the flap. So they are just worried about them. Yeah,
This one?
yeah.
Just give flush a little bit.
This is not a relevant question. Is it who to do nose surgery? I mean, it's already discussed. Who to do nose surgery is the question. It's not. Yeah, thank you, ma'am. You're also doing rhinoplasty. Yeah. Okay. Yeah. You learn by doing more and more. The patients are. Uh, yeah. Right. Okay. Right. When I started doing, we're basically ENT specialists, so the high deviations which we plan for septoplasty, where you have failures like conventional septoplasty, they are the ones basically who need external correction also. So that is when you start doing it, you actually benefit the patient. Because those patients usually don't go to, they don't have the, the resources or whatever. If we start doing those patients, then you can then start doing very good cases of rhinoplasty because the difficult ones. Yeah, it's just changed everything in those, especially those. I think if you just explain to them that the incision is just 3 to 4 centimeter incision, and it will not show off. And if you do have, in many patients, if you do a subcuticular closure also, so I don't think it's much of a problem for them. Yeah, 9th and 10th step.
One more.
It will be lower down, and even females don't have any problem with that.
Hair follicle.
Because the amount of material. No, I do it myself. It's not typical. Lower down, the chances of trauma to the pleura are also very little. Because the fundamental technique of subperitoneal dissection is the same in rib also. And we are trained in that because we're doing septoplasty.
So lateral crural overlay causes a reduction or it reduces the length of the lateral crus. It reduces the convexity of the lateral crus as well as it rotates the lateral crus upwards. So there is reduction in
from parallel, but that is not good. If you get it from Santosh,
projection is reduced as well as the rotation. You can rotate it upwards. Skin nahi yete na, vestibular skin is coming in this suture needle.
Metformin ones are very costly.
Nahi na.
But I would suggest 2 or 3 ones which I have got. One is a Rubish osteotome. That's worth buying. The other is a mallet which they're using hammer. Yeah. But it will make your osteotomy much better if you use the Teflon or the fiber mallet. And third is a cartilage cutting block they have. That's a yeah. Scissors you can buy from Carlin Fair. Fine. In Srinagar. Yeah. More of cookies and roses, so a lot of harm reductions. Yeah.
So both the crura are now shorter and straighter.
लगेगा
इधर दिखाएं इधर है
Madam, you put the diced cartilage now on the dorsum. Do you use?
Yes. Yeah, a freed ice cartilage for camouflaging purpose only, not for augmentation. So now I'm planning to put a septal extension graft and then domal sutures. This is a little bit of modification of septal extension graft, maybe a TO graft. Which I'll be fixing. Flush, please. So the advantage is I can give good projection to the tip as well as the rotation can be decided by rotating this graft. So once I fix it, I can rotate it and the domes can be fixed on top of it depending upon the desired rotation and the projection of the tip.
Very confident. Very confident. Because if you commit to it, then this will go back to you. But a lot of people initially give big results, but I'm not doing on it. It's considered up and down. Wide and they do very confident.
So I'm fixing it on the anterior septal angle.
Yeah. So for a floor like that, you can like it in that's that is something. There is a ground
Photo. Small. This is called as TO graft as a plastic surgeon from Turkey, Teoman Dogan, has described this graft. So roughly once I have fixed it, I will try to keep my domes on top of it and see where the projection would be and how the rotation would be. So I can whether I need to change the rotation. So, but this sounds good.
Can we see the lateral view? I think then we'll get a better idea.
Yes, lateral view, please. इथनं घ्या किंवा माझ्या पाठनं घेता येईल तरी घ्या. So still I have to suture these lateral, upper lateral and lower lateral cartilages so that bulbosity will reduce further. This will go inside.
Dr. Jyotsna, have you ever, are you doing the L reduction or you are planning to do in this patient?
No.
What is your take on L reduction? Have you ever done it regularly or you're planning to do it in some of your patients or?
Yes, LR reduction. LR reduction I do whenever that intercanthal distance, depending upon the intercanthal distance and LR flare. If it is LR flare is more than the intercanthal distance, needles, then I'd go for alar reduction, dermal sutures.
Oh, exactly, madam. At the sill area or in the lateral groove. Alar reduction.
Yeah, seal reduction or alar flare reduction, what you are talking about?
So both you prefer actually. Some people are now more conservative, go for only sill.
Yes, yes. It depends upon what is where is the widening, first of all, and then so whether there is LR base is widening or there is LR flare, depending on that, whether the base reduction, seal reduction is to be done or the flare reduction is to be done, that has to be decided. So, first of all, I do take consent of the patient for the extra incision and extra scarring in case if I have to do LR base or flare reduction. And this can be done in second stage also. So this patient was not very much keen on going for LR reduction or for more extra scars. So let us see, in case if he demands, we can do it at the second stage also. So that was the dermal suture. It is a That was the intradermal suture, taking again on the opposite side. And then the interdermal suture, including that TO graft I will be taking. Still, I have to fix the TO graft by taking 2 more sutures. Sir, how much time do you have? Do I have more? Thumb.
So you are not planning to keep a columnar strat or?
No. This
So
would
you're-
be sufficient.
So you're just planning, I think, a tongue and groove technique.
Tongue and groove, yes. Needle case zara bahar. Because his caudal septum is good enough. We have got a good TO graft. याला अजून एक सुचर घ्यायचं TO graft. सिद्धी हे का?
It's usually a graft which is, doesn't extend too much inferiorly, but only the tip of the graft is angled slightly beyond the caudal septum. And then you incorporate that graft in the between the new tip, between the domes. So it gives a sort of slight over projection of the tip, and that makes it look better. Yeah, they just want to know about the TO graft. What are its? Just want to have an idea of what the TO graft does look like.
Yeah, it is a triangular piece of cartilage. So it is, you can say, a modification of the septal extension graft. And usually it is fixed at the anterior septal angle. So this is a TO graft. So there is an entity, I have fixed it on one side of the septum, but then there is entity as called as tachograph also. So you put two teografts on both the sides and then suture it together. But what I feel, it makes this assembly quite wider. So I prefer to keep one graft only. Needle, please. If you see his photos, pre-operatively, his tip was little bit rotated on the right side. So I decided to fix the teograft on the left side. Loose कर. Right. So now my assembly or the tip I have fixed almost 1 centimeter above the dorsum. And you can see once I fix it, a type of diamond is formed, which will
How much above the dorsum do you overproject the tip, or you plan to overproject it?
usually 1 centimeter. If it is very thick skin, it is a little bit more. Otherwise 1 centimeter. So you can see the diamond shape, the tip and both sides. हो उरलेलं सगळं कर. बघू मला थोडं.
How many times have you tried the Costin technique of reducing the asymmetry in case of the middle crura?
Which technique?
Costin technique.
What is it?
Many a times when you make the middle crura longer because for rotation, you sometimes have a lot of asymmetry. So you can like you did in the lateral crura, you create pockets in the middle crura, and then you can
That
give
is the
relaxing.
lateral crural overlay you are talking about?
The middle crural overlay. So
Yeah,
you just give an
medial crural
incision
overlay.
and then you don't need
Yes.
to stitch them also. Some do stitch and some do not stitch.
Step
And then
please.
you take them with the columnar strut and that
Yeah,
causes
Pinocchio
the...
type of noses, I sometimes need this, that medial crural overlay. So that is done along with the lateral crural overlay and the medial crural overlay, both the techniques would be required.
Because many a times when you take the tip back, and when you see in the post-op, your patients, they have a sort of a columnar show, much of the columnar show. So by the Costin technique, you can reduce the show because it should not be more than 2 millimeter in the lateral profile. So it
That's
helps
true.
a lot.
Columnar show again depends upon the whether there is alar retraction, whether there is medial crura which are prominent, or so it depends upon the proportion of the both, how much is the columella show.
So what sutures are you giving right now?
I'm suturing this lateral crura and the lateral crus and the upper lateral cartilage, so as to give a better resting angle between the
And how many
upper
sutures you
lateral.
give?
Usually I give 2 sutures.
Yeah. Yeah, ma'am. It has come nice, madam.
Thank you. I don't think so tip graft.
Big applause for
is
you.
Thank you so much. Maybe just a little bit of free dice cartilage and suturing.
Can we just
Yeah,
see the lateral
kind of
profile? So
Yes, yes. Oh. Profile view, lateral. This is bulging. I'll have to reduce. I'm sorry.
The batten graft or something use, madam? Shield graft.
In this case, I don't think so that is needed. So when there is, when you want to give the fullness in infratip lobule, then the shell graft will be needed. The tip onlay graft sometimes, most often I use than the shell grafts just for tip projection. But in this case, even that is not needed.
The lateral profile view, audience is
Yes.
asking for.
Yeah, excellent. I think it's really looking
it's
nice.
very nice. Excellent.
You can see the
Projection
lateral
of the
profile.
tip.
Yes.
Or is there a shadow? And still I have to put a little bit of free dice cartilage so that this will come up little bit. तुम्हाला ना इथे येऊन घ्यायला लागेल photo.
Can we see the helicopter view? Top view.
Yes.
Josna,
Yeah.
I think in another 5 minutes we'll be shifting to the other one. You're almost through now?
Yes, yes. I am almost through. I have to take sutures and put the free dice cartilage. And then in case after Vikas is done, in case POP and all, in case the rest delegates wants to see, I can show that.
POP, etc.
You can see the profile.
Excellent, excellent.
Yes, ma'am. Excellent.
Projection.
Super.
Very nice.
Absolutely.
Even that bulbosity is gone totally.
Yeah.
It is flat. And on this side also, they want to see helicopter view also. So you have to, हाँ ये बाजू से आ जाइए. आप पहले वाला प्री ऑप का दिखा दीजिए एक बार और पोस्ट ऑप दिखा दीजिए.
Yes, I told her 5 minutes and we are on.
We can see the diamond also very nicely.
Yes,
Diamond is
the dome
very
points
good.
are also very nicely shown.
Yeah, a little bit of free dice cartilage for camouflaging. That's all. Maybe a little bit in radix because we have not touched it. And that's all.
Madam, what you use for skin suture?
Skin suture, again, I use either 6-0 ethylon or in case 5-0 PDS is there, then I take it along with the 50 PDS only. At present, I have 50 PDS, so I'll be taking with 50 PDS.
And when do you remove the PDS sutures?
No need to.
PDS sutures, I do remove after 7 days, these front ones, because
That causes irritation.
irritation.
Maybe we can use a rapid Vicryl.
Yes, we can use either rapid Vicryl also, or
Yeah, that absorbs early.
that's true. Huh? Oh. Hmm. So I'll be doing the keeping the POP. Usually I keep it for 15 days, 2 weeks. After the first POP becomes loose, I change the POP. That is any time between 7 to 10 days. I keep Doyle splint so that patient is comfortably breathing after the surgery. And even that I remove either between either on the 4th day or 7th day.
Okay, Josna,
Yes, sir.
now that your job is nearly complete, except for that last bit, can we
Yes, sir.
now shift to Vikas because he's got his patient anesthetized and waiting now. But I think
Yeah.
you've given us a absolutely superb demonstration, and congratulations and thank you for doing this for us.
Thank you so much, sir. Thank you
Oh,
for giving the
no.
opportunity.
The audio visual was
Thanks
also
to-
excellent.
No, the audio visual and your anesthetist both need to be complimented.
Yes, definitely.
Madam, great dissection. Personally, also, I am complimenting you, Dr. Lata Devi from Karnataka. Thank you so much.
Thank you, madam.
Thank
Thank you,
you.
madam. I thank Kirtane sir as well as team MacLeods, the audiovisual team,
Thank you, ma'am.
and my hospital staff.
Yes.
And not last but not the least, all the delegates. Thank you so much.
Thank you,
And
ma'am.
in
Thank you
case,
so much.
in case after Dr. Vikas is done, maybe after 15, how much time, sir, he's going to take?
He's already on the screen, ma'am.
Okay.
Already.
Yes, you can go
Vikas,
ahead.
sir, how much time would you take, sir?
After that, in case
Whatever you-
POP or anything is to be
He'll need 40 minutes, ma'am.
shown. 40 minutes, okay.
Yes.
No, I'll finish off faster.
Okay,
All right,
let
so-
us see. In case POP is to be seen, then I'll show that.
Fine.
What are you seeing? You're seeing the external picture?
We are
What
seeing
is-
one young, handsome man on the screen.
Sir. Should I start, sir?
Yeah, you can start, Dr. Vikas. Please start.
All right. So this is a 36-year-old male patient from Agra who has been operated twice for obstructive sleep apnea, one for the nose, one for nose and soft palate. So still he has got a deviated septum anterior part, and he has got, something was done on the soft palate, tonsillectomy was done, but his palate was pretty long. So I have already done uvulopalatopharyngoplasty, the revision one, and he also has got a base tongue enlargement. So I'll ask the audiovisual guy to first play the dice. Can you play the dice? Because without understanding the dice, you may not be able to understand the case.
Here you are watching drug-induced sleep endoscopy with this monitoring. The 35-year-old male with history of snoring, choking, and postnasal drip. He has been operated twice before, once for the nose and once for nose and throat both. So you can see the turbinectomy, turbinoplasty, whatever, already performed on both the sides. His body mass index is 30 and his AHI, apnea-hypopnea index, is 36. I can see some large middle turbinates here. Now, if I try to go inside, his base is around 86, so it's not completely sedated. So There are no significant adenoids. The salpingopharyngeal folds, I would say, are grade 1 by advanced classification between 25 to 75%. He still has a persistent retropalatal collapse in spite of the palatal surgery in the second go. You can see a complete collapse over there. And you can see the lingual tonsils, pretty large lingual tonsils. Completely pressing onto the epiglottis. Now his base is around 73, the perfect base, and you can see the lingual tonsils pressing onto the epiglottis, and both a primary and secondary epiglottic collapse happening, both primary as well as secondary epiglottic collapse. If I keep his mouth closed, still you can see the epiglottis completely collapsed at a base of 69. That is, so the epiglottis is lax, the median glossoepiglottic ligament is lax, so epiglottis is, that's the primary epiglottic collapse, and obviously it also collapses secondarily because of the lymphoid tissue in the base tongue.
Yeah, good afternoon, Dr. Vikas. Dr. Raut here. So what is your plan?
Yeah, so as you can see inside, are you getting the endoscopic picture?
Yes, just.
All right. So see, this
They're
is the base
getting.
tongue. This is the base tongue. I have already put a suture here to keep the base tongue, the tongue pulled out. You can see the tongue suture, and I'm using a tongue depressor which is one size lesser.
Can you elaborate how put the tongue suture in this case?
How about the
tongue suture?
Tongue suture. All right. So I have taken the tongue suture in the middle of the tongue so that you can pull the tongue out as much as you want.
Okay.
Right? Because unless you pull the tongue out, you'll not be able to see the tongue base. Now, see, this is the anterior 2/3 of the tongue. And this is the posterior
What the number of tongue blade you have used for mouth?
Four.
Yeah.
Four.
Four.
Four. Normally for an adult, you would have used 5. Here, I have used 4.
Yes. Yes.
Right?
Yeah.
Now, in his case, it is mainly a lymphoid based tongue. And you can see this is the filiform papilla, anterior 2/3. And this is the posterior 1/3. And this is the foramen cecum. All right?
Okay. Yes.
So we have to operate, we have to remove the lymphoid tissues right from the foramen cecum to the median glossoepiglottic fold. You cannot see the epiglottis right now.
Yes.
Can you see this is the epiglottis?
Yes, yes.
Epiglottis. So I put a patty below the epiglottis so that excess water does not go inside. Now, can I get the external camera for a minute? External camera, please. Yeah. So this is the plasma coblation wand. I have already done the UPPP. With the same wand, now I'm going to bend it by almost 30-35 degrees so that I can reach the tongue base easily, right?
Yeah, this is precise max.
No, this is EVAC 70, the standard EVAC 70.
Okay.
Now we can get the endoscopic picture, please, audiovisual. So I am still on the setting of 7 and 3. I can go up to the setting of 9 and 4. All right. So I'll start with the setting of, go to 9 so that we can finish it off faster. So I'm going to setting of 9, which will ablate faster, and coagulation to 4. Now our aim here is not to enter the lymphoid and muscular tongue base. And our main area is to take care of, see, even if you do not remove these tissues, it's all right. We have to remove tissues which are in the
lower part,
which is in the vallecula. Can you show? So I'll ask Dr. Patel, my assistant, to show me the epiglottis. Can you show the epiglottis? So this is the technique. Earlier we used to try to see it from inside. Now if he's pressing from outside, can you see the epiglottis now?
Yes.
That's the epiglottis. So our aim
what
is
maneuver he did? to visualize?
Yeah, see, he's pressing the epiglottis, the larynx from outside.
Okay.
He's pressing the larynx from outside. And
What scope you are using?
Right now I'm using 70, but you can use 45. I normally use 45, but right now 45 is actually at my other clinic, so I'm using 70.
Okay.
You can use 30, 45 or 70. It doesn't matter, but you should be able to see the median glossoepiglottic ligament. And here you have to go very slow. Now you see, this is the epiglottis. I want to do glossoepiglotopexy and removal of all these lymphoid tissues. But I do not want to get into
vallecula is full of lymphoid tissue.
Absolutely. So I'm starting to remove the lymphoid tissues layer by layer, starting from the midline.
What will be the lateral limit?
Lateral glossoepiglottic ligament. Median, start with the median glossoepiglottic ligament. The median limit is the median glossoepiglottic ligament, and lateral limit is the lateral glossoepiglottic ligament. Can you see a lot of saline flowing?
Yes, yes.
So saline, as long as it is saline only, there's no problem when it goes into the larynx. But obviously I have kept a cotton patty on both the sides to protect the saline from going inside. Most important area is the midline, and you do not get large vessels in the midline. So you can be very peacefully, you can operate in the midline. And these are all lymphoid tissues. So you'll not get a large blood vessel in the lymphoid tissue. All right. And see, the median, the lingual surface of the epiglottis, we have to anyway create a raw area here.
Yeah.
All right. We are supposed to do glossoepiglotopexy. So I'll not bother about the damage to the mucosa of the lingual surface of the epiglottis. But I'll not create any damage to the laryngeal surface of the epiglottis.
You require some synechia over that area.
Yeah, obviously I require synechia here, na? But see, I have to go pretty deep inside right now. This is the lateral part. This is the median part.
Correct.
All right.
Yeah.
Laterally, you will get vessels. So tube is our guide. The tube will tell us that we are. So if you are not sure, you can coagulate. See, this is coagulation. You can first coagulate and then ablate. That's also possible. But my aim is first to see the median glossoepiglottic ligament. This is all the lateral part. Laterally, I will ablate. I will not, sorry, I will coagulate. I will not ablate laterally. I am only coagulating right now. See, this is the lateral glossoepiglottic ligament. This one.
Yeah.
I do not want to go too much lateral. Because you get all the vessels laterally. Now, let me again reorient and start removing lymphoid tissues on the median aspect.
Are you addressing tonsil here? No?
Sorry?
Are you going to take out tonsil?
It's already done.
Done. Okay.
Tonsillectomy was done before the patient came to me. I have performed a revision uvulopalatopharyngoplasty. I've already done that in the last half an hour. Now see, this is the area, right? This is the median.
Okay.
So I need to remove all this lymphoid tissue.
This lymphoid proliferation is because of post-tonsillectomy
No.
lymphoid proliferation or what?
No. God only knows why it happened. Lingual tonsils is a common. Can you see the muscle of the tonsil?
Yes.
I have removed it completely. There is no lymphoid tissue left here, but I am still not happy with this area. There's still a bit of lymphoid tissue. Unless I remove this lymphoid tissue in the midline.
Looks like ethmoidal polyp.
Yes. Unless I do that completely, the airway of the patient will not open, and I'll not be able to perform glossoepiglottoplexy. This is lateral, right?
Yes.
This is lateral. So anyway, I am supposed to coagulate the mucosa on the lingual surface of the epiglottis. Now I need it to be lifted little more. Can you press it from some other side? Because my aim is, this is my area of interest. Can you see this?
Yes.
Quite deep. And I need to remove all these lymphoid tissues till I see my median glossoepiglottic ligament. And this is a very difficult area to reach. In case it starts bleeding, you have to re-intubate, then your anesthetist will go and hit the same area. It will bleed even more, and your patient cannot breathe. So the surgery is very simple, but the consequences of a complication is very, very bad. Therefore, tongue-based surgery is,
Yeah.
So because usually this bleeding occurs how late? I mean,
yeah, sir, if it is
your
on table.
experience.
Yes, sir, on table there is no problem because obviously your tube is inside.
Yeah.
But if this patient bleeds after 7 days, 10 days, secondary bleeding.
Yeah,
and
so
then
that is usually occurs after about a week.
Absolutely, sir. Because then there is secondary infection, and therefore, if you have only done the lymphoid tissue like what I'm doing here, obviously I'm not opening up any big vessel. So I do not expect a large, big bleed. But if you have gone into the muscles of the tongue, then obviously if the bleeding happens, it can happen from a large vessel, which is an artery or something. Then you have to take the patient inside. That is a challenge, because if you do a tracheostomy, then there's no problem. But if you try to re-intubate, your anesthetist would go and hit the same area again. Right now, what I'm doing here is I'm only coagulating. I'm not ablating you. See, this area I ablated easily, but this area I'm only coagulating. Now, see, this is the median glossoepiglottic ligament, sir. Can you see this?
Yes, very clearly.
That is my limit. This is the median glossoepiglottic ligament. Now that I've seen my limit, I'm coagulating all the lymphoid tissues. I am on a setting of 4. If required, I can ablate, but if I ablate, then there's a chance of opening a vessel. If I do not ablate, then there's no chance of opening a vessel.
So you're just coagulating them.
I'm only coagulating right now. This is what I learned over a period of time. Now, I'm still not happy with the ligament. Can you show me a little more, Swam? So I'm going around the ligament and I'm first coagulating it. Now see, this is still a lymphoid tissue which is sitting over there. This will not let my epiglottis come up. So I have to, this is the ligament. I'm going all around the ligament and coagulating the ligament to the fullest. Once I've done that, then I'll see if I can.
Light क्यों नहीं आ रहा है इस पे?
Is the picture
Shadow
quality
array.
all right, sir?
Yes.
So right now, only coagulating, because this is the minimum which will help the patient without any complication. But then obviously I want a better result. After I have done this, I'll assess if I can do a little more. Can you now see the tube is on the left side? Can you pull the tube on the right? Can you pull the tube on the right? All right, thank you. So Dr. Patel has actually, earlier I used to do everything from inside, but he did, he helped me a lot by doing everything from outside. Now see, sir, how nicely he is showing me everywhere, all around the median glossoepiglottic ligament I'm able to go. This was actually his idea. Now this lymphoid tissue is quite a bit. I'm ablating it now.
What is he doing? He's giving pressure from the outside and moving the tube?
From outside, sir. Yes, sir. He is manipulating everything from outside.
Okay.
It's a wonderful technique that he helped me with, because earlier we were struggling to how
Can
to...
you ask Dr. Patel to maneuver what he's doing?
All right. I'll show you one minute. I'll show you. Let me just complete this work and I'll show you. So now, beyond this, we honestly need not go too much lateral. And certainly we need not go into the muscles. All right, now see what he's doing. Are you able to make out?
Yeah, okay.
Yeah. So he can
Lateral
press. Yeah. Can you do that? See, whatever I want him to do, he's able to show me everything very nicely from inside. All right. Can you? So this little bit of tissue. Now that my major work over here is done, I have reached till the median glossoepiglottic ligament. Let me see if I can ablate. I'm ablating absolutely in midline. Because if I ablate, I'll create another few millimeters of space. Push. Correct. Thank you. Fine. This is the ligament. There's no space. I want to take off this lymphoid tissue also, if I can.
With this limited ablation, how many days you ask for ICU?
No ICU. He'll be extubated. He'll go home by the evening, sir.
Okay.
Yeah.
Oh, that
he will have, after 6 hours, he will have liquids, ice cream, and he'll go home. I mean, he can go home by the evening. But obviously, we'll keep him. Will not
there will
send
be no
him.
tongue-based edema.
No,
are you
because
putting in a steroid also?
obviously the anesthetist is giving a steroid, but there'll be no tongue-based edema because I'll finish the work in 15 minutes.
Okay.
15 to 20 minutes is the time that you can keep the tongue compressed. If you keep it for more than that, then you'll get edema.
Okay.
So if I have to do more work, I'll remove the tongue blade and I'll reapply after 2-3 minutes. See how much of redundant tissue is there. I'm just coagulating all that redundant tissue. But the laryngeal surface of the epiglottis is absolutely clear. Can you now? I'll just give a little bit of energy to the tongue base here, coagulation energy, so that the whole tongue base shrinks by a few millimeters more. But as you can see that I have not opened any vessel.
Yes.
I'm in the submucosal plane only. So even if there is infection, secondary bleeding will be very, it will be a spotting kind of a thing. I am only, थोड़ा सा और दिखाओ मैडम, थोड़ा सा ये वाला. नहीं, ये दिखाओ, ये वाला. थोड़ा सा ऐसे चाहिए. I'm just a little unhappy about this part. हाँ, थोड़ा उठाओ ना. Thank you. So there's a little bit of lymphoid tissue here which I want to actually ablate, but I'm not getting enough space to ablate.
Any extra precaution patient has to take post-operatively? If
Any extra
precautions not to do or avoid, yes.
Yeah, no hard food, liquids for 15 days, lot of water to drink. थोड़ा सा last एकदम. See, I am absolutely.
Yeah, that's the
on-
inferior limit.
Yeah, that is the limit. ये थोड़ा सा जो tissue बचा है ना, I just want to completely take care of that. इधर तो अपने लेफ्ट साइड. Yeah. So earlier we used to do epiglotectomy. After this epiglotopexy, we have almost stopped doing epiglotectomy.
So what is the AHI score in this patient?
36. Now see, now we can still remove a little bit more if you want. This is the ablation now, because this is pretty superficial.
You are coagulating first and those coagulated tissue are ablating.
The ablation is always better, but ablation has a risk of bleeding. Coagulation does not have that risk of bleeding. So when you go very deep into the recess, you first first coagulate, then only you ablate, because छोटा मोटा कोई vessel रहेगा भी. Now I'm ablating. Strictly in the midline, I'm ablating. They have removed every bit of lymphoid tissue from this area. Can you make out, sir?
Yes, yes.
There's no live lymphoid tissue left over that. Midline, I have completely removed every bit of lymphoid tissue. Laterally, I have coagulated all the lymphoid tissues. Now this epiglottis will cling on to the.
Will you prescribe some PPI or anti-reflux? What could be
Yeah, every patient. Every patient. Now all this area, what is pretty lateral, I will only coagulate and leave, because this area is not really causing problem. Problem was only in the midline, and here you get all the vessels. So you coagulate all this area as much as you want, but don't ever get into the vessels. Don't go into the ligament. So this surgery is almost right.
Yeah.
So this surgery is over. If you want to, if you still have time, then I can possibly show you the suspension bridge barb. This was the uvulopalatopharyngoplasty done.
How much time it will take?
10 minutes?
Yes, we have time.
Great. So microscope, please. Microscope, please. So I have just kept the barbed suture part pending, so that if people want to see the barbed suture part, microscope.
A lot of delegates are there.
Oh, very good. So barbed suture is it's a non-absorbable barbed suture.
Vikas,
Sir.
Jyotsna just wants to show her final results. So we'll just
Yes,
see
sir.
that 2 minutes and we'll come back to you.
Perfectly all right, sir. I'll take 2-3 minutes for the microscope anyways.
Yes. Mr. Dinesh, please. Ma'am, we can see your patient now.
Yeah. Can you hear me? Lights?
Yes, ma'am. Yes, ma'am, we can hear you.
Yes. So this is a helicopter view. You can see light here. Yeah. The pre-op and post-op. Can you appreciate?
Absolutely fabulous. Thank you so much.
Thank you, sir. And
Absolutely.
the lateral view. कितना सा light effect.
Here is your moderator. Your comments, please. Dr. Lata.
Madam, it was wonderfully conducted surgery. We could see all the steps very nicely, and audiovisual was also good. Your explanation for each step was also very good. On the whole, it was wonderful presentation. Thank you,
So
ma'am.
much. I just put that free dice cartilage, even that makes a lot of
Right,
difference. So I thought I'll just show the pre or post op comparison at the end of it.
Okay, madam. Thank you.
Thank you so much.
Excellent surgery, Jyotsna.
Thank
Excellent
you, Ritu.
surgery. Very well demonstrated. Audio visual was also very nice.
Yes,
Could
definitely.
see all the steps clearly. We're all ready to do the rhinoplasty now.
Great, great.
You will get quite a few for revision rhinoplasty soon. Anyway, thank you so much. God bless. So
Thank
we're
you,
shifting back to Vikas. Okay?
Yes, sure, sure.
Okay, bye.
Thank you.
Hello.
Yeah, Dr. Vikas, we are with you.
Yeah, hi. So are you able to see the inside view?
No. Yes, now it's
All
clear.
right. So you see, this was a revision uvulopalatopharyngoplasty. I have resected the uvula. The palate was really very long. It was till here, right?
Yeah.
Tonsillectomy was done. So you can see I have taken the vicryl stitches for the lateral side on both sides. Can you see that?
Yes.
So obviously we have a lot of space behind the soft palate now, but there is another technique that we use. We called it suspension bridge pharyngoplasty, for which we use a V-lock non-absorbable suture. So this will not
V-lock.
let the soft palate fall anteroposteriorly. Lateral I have already taken care with the vicryl, and I'll use the V-lock. It will hardly take 5-7 minutes. So we use the pterygomandibular raphe. It's a published technique, published last year. So that's the pterygomandibular raphe.
Yeah.
From right pterygomandibular to the left, will pass on a non-absorbable barbed suture. So if you have to feel the raphe, you can put the finger between the maxilla and the mandible and you will feel the raphe here. So once we start from the right side.
The idea is to pull the uvula anteriorly.
Uvula is already resected.
Palate. Okay, palate.
Yeah, but see, there's a limit to resection, right? Uvula was here. I have already created that space. But still this soft palate, the tongue will fall on this, the soft palate will collapse, and you cannot resect it much higher. So this is the raphe. I'll start 6 to 7 millimeter lateral to the raphe, go pretty deep, because there's a loop that needs to be accommodated. I've come in the supratonsillar area here, and so this is a unidirectional barbed suture. Can you see this loop, sir?
Yeah.
So my raphe is here. My loop should be completely buried inside.
You cannot pull out the suture.
No. Once it is inside, you cannot pull it out. It's barbed. So now this loop has to be completely buried inside, because it's a non-absorbable suture. So nobody had used a non-absorbable suture in the soft palate before. Now can you see it is completely gone inside?
Yes.
Now it is sitting on the pterygomandibular raphe, which is here. All right. So it cannot extrude. Now we'll take the second. We again go back from the same place. Again, very, very deep. And completely very deep, because it has to take the whole weight of the palate and the tongue both. See, the tongue will fall in on this, correct?
Yes.
So this not let this is the whole purpose of this surgery. Can you see how it is pulling the soft palate anteriorly?
Yes.
And this is hinged on the pterygomandibular raphe. So this will not let the soft palate fall posteriorly. It will also support the tongue, which will fall on the soft palate. So this is also a surgery for the high tongue base. Without touching the tongue base, you can support the high tongue base. Again, from the same point, very deep, We'll try to reach the raphe.
You're coming posterior to the raphe?
Lateral to the raphe.
Lateral.
I want to reach lateral to the raphe. If I cannot, then I'll take one more bite. Can you see I'm lateral to the raphe?
Yes.
All right.
Very clear. Yes.
I'm lateral to the raphe. Now, from right to the left. Now, this soft palate cannot fall posteriorly. But what I'll do is I'll take one turn more. I'll come from left to right again. So it will be reinforced. Are you able to see, sir? Is it in focus for you?
Yes, yes. Will it cause nasal regurgitation for some time?
No, because I have not touched the levator palati muscle. Na? So the levator palati is much higher. I am only working below the levator palati.
Okay.
All right. So very, very deep, because if you do not take it deep, then this is a non-absorbable suture. It will extrude. All right. Same place, very deep across the midline. And we'll go to the right side from where we started. So this was published last year. I'm doing it since 2019. But obviously, since this was the first time, I was only hoping that this does not extrude. And I got my initial failures because I was not very deep. A few of my patients extruded because it was superficial. Then I was doing the right lateral and the AP both with the same. That was another mistake possibly. Now see, again, I'm quite lateral to the raphe, right, sir?
Yes.
I'm using the strength of the raphe, which is always anterior and lateral to the soft palate. Now, right?
Are you
and
putting any knot?
No, there's no need for knot because it's a barb suture. Na?
Okay.
Now, what I'll do is I'll just make a U-turn. I'll make a U-turn here to further lock it. And then simply cut it off. Scissor. So that's the suspension bridge pharyngoplasty for the anterior collapse. Now, see the result of this. Now, this soft palate is like it cannot go behind. Even if you let me put some weight on it. Even if you put weight on it, it cannot go behind.
Yes.
But when you swallow, levator palati is here. It can move sideways because the hinges are here. It can always move sideways. So it can move up for swallowing, but it cannot fall behind for snoring.
Collapse.
That is the concept. And the snoring literally goes away unless there is some other factor. Like in this case, base tongue, upper part of the tongue is also large. Obviously, he has to reduce weight. Now see, when this tongue falls, this tongue will fall right on the, can you give me some? Now this tongue is sitting right onto the soft palate. Can you see this?
Yes.
But it will not let this tongue collapse behind because it is supported on both the sides. Right, sir? I will just examine the operated area once more. I understand that there's no bleeding. You have a 70-degree ready?
Because Deepak here, Deepak Dalmia.
Yes, Deepak.
Actually, I have two questions. One is how you decide that at this stage means the nasal regurgitation will not occur after surgery. How you decide that? And when you pass these stitches, the palatine artery will be there. Sometimes you may pierce the palatine artery. So how to prevent that or avoid that?
1 second, Deepak. Give me the 70-degree, please. So, Deepak, till the time you do not damage the levator palati, all right? Levator palati is the muscle for solving. Sorry, my mask is down. Mask नीचे कर दो एक बार के लिए. आवाज नहीं आ रही. Can you just pull the mask down? Yeah, Deepak.
Yes,
unless you damage the levator palati, there will be no problem with the swallowing. I have only resected. All right, so there's no, can I have the endoscopic picture? So there's no bleeding from that area.
Yeah.
All right, so I can extubate this patient easily, right? Now, you should never go inside to re-intubate this patient. So obviously, the BIS monitoring is happening. BIS monitoring, it should go above 85, 90, then only you should extubate. All right, thank you. So we can take the camera and the questions on that side. You can. Deepak.
Yes, yes.
So the levator palati, if you do not damage, there's no question of regurgitation. No question of rhinolalia.
Okay.
If A, B, C, D, my voice will become like this if my levator is not working. All right.
Okay.
Because I have been lower to the levator and I have used coblation, so there will be no fibrosis pulling the soft palate down. If you use cautery, you can still cause regurgitation because the soft palate will be pulled down by the fibrosis. It will become hard palate, right?
Okay.
So you do not use cautery on the soft palate.
Okay,
So
how will calculate how lower to levator palati? Any calculation there?
Correct. So yes, so there's a line. If you see the anterior pillar to anterior pillar line,
okay.
When you do tonsillectomy, you see your anterior pillar.
Yeah.
If you remain in the line joining anterior pillar to anterior pillar, you can never, ever in any single case damage the levator palati. That is 100% sure. In some cases, you have to go even above that line. Like in this case, this was a very long soft palate. Okay. So I have even gone higher and resected more.
Yeah.
But if you follow that line of anterior pillar to anterior pillar, I mean, it's not published anywhere. I have to write a paper on that. Anterior pillar to anterior pillar, you will never, ever get a levator palati problem.
The upper part of the anterior pillar to pillar. Means
the anterior pillar, tonsil ka anterior pillar.
Upper pole of anterior pole. Yeah.
Upper pole of the tonsil to upper pole of the tonsil. Yes, absolutely correct. So if you remain in that line, you will never ever in any, it's normal anatomy. In any case, small palate, long palate, you will never, but you may still underdo. In long palates, the length is more at times, like in this case. Yeah. Length was more. So I resected more than that.
But in this case, you did much higher to the anterior pillar. Upper
yeah, but still it will not say. I was seeing when I was dissecting, I was seeing the levator palati fibers will be horizontal. I was only dissecting the posterior pillar, which are lateral, and the musculus uvuli, which was vertical. So you see the direction of the fibers. As long as you are dissecting the vertical and the oblique fibers, they are not levator palati. You see the fibers.
Okay.
It's very
how long you give steroids after this procedure?
Nothing.
Steroid oral.
No, only Only one dose of steroid which the anesthetist will give for the airway.
Okay.
No more steroids.
For post-operative pain?
Pain. Yes, we give that patch. What patch?
Yes.
Buprenorphine patch. They put a buprenorphine 10 milligram patch.
Okay.
5 to 7 days it will take care of the pain. Yes. And obviously you give paracetamol and ibuprofen paracetamol combination. Sometimes even tramadol. Pain is a problem. I totally agree. Pain is a problem.
Yes.
Okay, thank you very much. It was a wonderful demonstration and presentation.
Thank you. Unfortunately, I could not demonstrate yesterday because of my health issues.
No. I hope we get.
My cardiologist asked me not to touch. I said, I'm fine. He said, nahi, aaj nahi karna hai. Kal karo.
Thank you very much, Vikas. Wonderful demonstration. And I'm glad that you could finish your previous commitment and come and join us.
Yes, sir. Thank you, sir.
It shows your commitment to teaching.
Sir, that was a much better case. I did a full bilateral frontal to sphenoid, septoplasty, tubnoplasty, uvuloplasty.
There is always the next time, Vikas.
Yes, sir.
Okay. So we'll have
Thank you,
you
sir.
again and again. Okay. Thank you.
Sure, sir. Thank you, sir.
Thank you. Bye.
Privilege, sir.
Thank you.
Thank you.
Thank you, Vikas, sir.
Thank
so,
you.
with this,
We're switching off your camera now. Okay. Vikas, we're going back to the auditorium now. So you'll be off air now. Thank you. Bye.
Thank you, sir. With this, I request Nitish sir and Dr. Kirtane sir to please felicitate the moderators of the previous surgery of Dr. Jyotsna Jagtap. I request Dr. Lata Devi to please come on the stage. I request Kirtane sir to please join. Now I request Dr. Ritu Seth to please come on the stage. I request Dr. Shaukat Islam to please come on the stage. I request these sir to please felicitate Dr. Khageshwar Raut sir. Thank you, sir. Now I request these sir to please felicitate our program director and chairperson, Dr. Milind Kirtane sir. So that was welcome. I kindly request you to give your concluding remarks.
I was just telling him that it's a joint effort. I think your team has worked extremely hard. It's not easy to coordinate so many centers. You've got a very good audience, and we'll also get a feedback from the 30 centers. Getting that feedback would be important. So I think congratulations to all the presenters. All of them did a fantastic job. And I hope we have this as an annual feature so that we can look forward to more surgeries. We've got a lot of surgeons here who can demonstrate surgery. So thank you once again, and thank all of you for your patience and your participation. God bless.
I request Dr. Amit Kamra to please give the vote of thanks.
On behalf of MacLeods, we all thank you, all the delegates, for the 2 days. We hope that these learnings will go a long way. We thank our program director for organizing this, the entire MacLeods team for putting everything together, all the operative faculty, all our moderators, all our panelists, the DocMode team for their partnership, the digital infomedia team for bringing everything together, and finally, the Hotel Taj for their facilities. Thank you.
So with this, we conclude this ENT, ASCENT ENT surgical workshop. Thank you so much.